emerging health schools in Sudan, Uganda, and Kenya. He serves on 2 international health commissions, the Lancet Commission on Investing in Health and the Lancet Commission on Global Surgery. Should I stop and let you talk?
Yes.
Okay,
Thank you
thanks.
very much. Thanks a lot. So, thanks to you for the very kind opportunity to present today. Essentially, what I was asked to do is to try and link some of the innovation discussions with the dialogue right now around global health goals and goal setting. So in the next kind of 20 minutes, 25 minutes, I want to talk about some of the thinking about where we could be within a generation, how we're going to get there, and then what role innovation is going to play. So if we think about global health goal setting right now, obviously the big one is the Sustainable Development Goals that all UN member states have signed up to. Very aspirational. And then I wanted to briefly mention 2 other efforts that I was involved with that are less about aspiration and a little bit more technical in nature. One was a modelling study, and one was a time trend study, Global Health 2055 and 40 by 30. So we've moved from the relatively simple Millennium Development Goal era with 8 clear goals, 3 of which were health related, to a much more complex goal setting era now. We've got the 17 goals with 169 targets. One of those is health related, that's goal 3. The economists smartly called these targets the 169 commandments, when they said they'd be worse than useless, upsetting a lot of people at the UN. I was at a meeting when this came out, there's Marxism saying there's like no target left behind. But you know, there they are. We are now on the hook in the next 15 years to achieve within goal 3, 9 targets. It's really an incredible agenda that the world has agreed to. It's getting maternal mortality down to under 70. Many of us in the scientific community think that is impossible. It is ending preventable newborn and under 5 deaths. So there are 0 targets. It is ending AIDS, TB, and malaria, right? So we have to end AIDS, TB, and malaria within 15 years. Reducing premature mortality from non-communicable diseases by a 1/3, probably more realistic. And then there's goals on substance use, on road traffic accidents, on sexual and reproductive health. We are to achieve universal health coverage. Not well defined in the SDGs, although the WHO and World Bank are essentially defining it around getting people out of poverty who are being pushed into poverty by medical expenses. So there's 150 million people a year. Jim Kim essentially says that this target is from 150 million people pushed into poverty every year for medical costs down to 0. And then it's access to services amongst the poor. And then hazardous chemicals and so on. So we have a very large agenda. Many of those targets really are aspirational, particularly the 0 targets. As far as we know, they weren't based on much, by the way, any kind of scientific or sort of technical modelling. I was involved in 2 efforts that had a little bit more science involved. One of which was, I had the great fortune of leading the writing of a report called Global Health 2035, the Commission on Investing in Health, chaired by Bill Clinton's Treasury Secretary, Larry Summers, and Dean Jameson, who leads the Disease Control Priorities Project over at UCSF. And what we did, and I'll talk a little bit more about it in a minute, but what we did was to say, well, where could countries be if they were to aggressively scale up known evidence-based health interventions? And we had certain assumptions about how quickly they could scale up and what those interventions would be, although the list of interventions is very non-controversial. To say, based on a sort of best performer scale-up model, if all countries could do as well as, say, Rwanda or Turkey or Bangladesh, where could they be? And essentially what we found in this approach was what we called a grand convergence in global health. What do we mean by that? Well, the whole world used to be converged. We were all in the same boat 200 or 300 years ago. The grand convergence already happened. We all lived appalling, disastrous, miserable, awful, terrible lives. We all died very young, and child mortality was high everywhere on the planet. 4 out of 10 children dying everywhere, rich and poor countries, and women routinely died in pregnancy. And this was kind of the universal condition of human misery, everywhere. And then what you start to see around 1750 is this great, grand divergence where the rich world, this is child mortality, China versus Sweden, you start to see in the rich world child mortality plummeting through interventions that included health sector interventions. And the poor world left behind a grand divergence in global health. But look at what's happening to China in the last 30 to 40 years, something very extraordinary. You see China converging on Sweden again, largely, not entirely, but largely through health sector interventions. And what we showed in our report is that if the right steps are made, and if the right steps are taken, the right investments are made, you could actually see most low and lower middle income countries being where China is today, or Chile, or Costa Rica, or Cuba, the so-called 4C countries, countries that used to be poor and had high mortality, and that managed to bring their mortality down. We could reach a grand convergence in global health, universally low levels of infectious maternal and child deaths everywhere on Earth. Why do we talk about the 4C countries? Largely because they showed the way. In 1991, the World Bank classified them as poor. They had very high child and maternal mortality. And they were able to bring down their mortality despite political vicissitudes, geographic problems, earthquakes, and so on. Thirdly, just wanted to mention a study I was involved with Richard Pito and a very large team of researchers, really looking at time trends of the past and extrapolating forwards, not a huge amount more than that. Published in the Lancet last year. We called it the 40 by 30 study. And what we showed was that it would be possible, with a modest acceleration of recent trends in the last decade, for all countries to achieve a 40% reduction in premature mortality by 2030. By premature mortality, we mean any death before the age of 70. We picked that. Peter had just turned 70 years old. So that's based on mortality trends and a moderate acceleration of recent mortality trends. This, by the way, I love this picture. This shows the probability of dying in men from 1970 to 2010 across different age groups, as you can see, or overall in black from 0 to 69. You can see some very dramatic declines in mortality, astonishing declines in mortality. Places like Egypt or Indonesia. Some of you astute observers will also see there were 3 blips where mortality increased. That's South Africa and Brazil from HIV/AIDS, and that is Russian Federation from anyone? Did someone say it? Vodka. So that's entirely alcoholism. So, on any of these goals, how would we get there? Let's take Global Health 2035, because we were able to sort of empirically show how you might get there. First is very aggressive scale of today's tools. So as I said, in our model, we took a suite of proven evidence-based interventions, and we assumed, and it's a very big assumption, but for the model, we assumed that all low and low middle income countries could scale up tools at a rate that was seen in the best performing country of the last decade. So it was a massive study. We went through this by intervention. We looked to see which country had scaled up that intervention the quickest. And then in our model, we assumed all countries could do so. A big assumption, of course. But at least it shows you where you could be based on somewhat of an empirical approach. So for example, here are the current coverage rates, say, of syphilis screening in pregnancy or stillbirth attendance in low and low middle income countries. And this is where they would be if they adopted high performer, best performer rates. So it's obviously very aggressive scale. But that, of course, will need to strengthen health delivery systems. And in the poorest countries, most of the costs of achieving grand convergence, about 2/3, will be for health systems strengthening. And crucially, we cannot achieve grand convergence with today's tools alone. Impossible. In fact, the SDGs are a complete and utter fairy tale and fantasy without innovation. Literally humanly impossible to achieve the goals without very aggressive scale up, both on the financing side and R&D side on on innovation. There have been a few exercises recently. Most of you probably will have seen the Innovation Countdown 2030 report to try and say, okay, well, what are some of these game-changing innovations going to be that can help bend the curve and get us towards convergence or get us towards the SDGs? Inhaled oxytocin, for example, postpartum bleeding, more effective vaccines for HIV, TB, malaria, and so on. A couple of weeks ago, I had the tremendous fortune of guest editing along with Carlos Morel at Fiocruz, who, as you know, is leading Brazil's Zika R&D effort, and one of the most inspiring guys. We had the great fortune of spending the last year and a half commissioning a collection of papers in PLOS on what some of those game-changing innovations might be across a series of diseases. And we wrote an overview editorial, and just to sort of reiterate the point we talk about, these bold zero targets being total fantasy unless there's a really massive global R&D effort. So you're not going to end AIDS, you're not going to end TB, you're not going to end malaria without effective vaccines, much better medicines. I mean, I'm a physician and we call TB therapy short course. Only doctors would call a 6-month course of treatment. Nasty drugs, toxic drugs, short course. And rapid point of care diagnostics. And as I said, we know of no credible research that says you can get to zero just with today's tools alone. By the way, I would love everybody in this room, I would love every student at Duke and every student who's interested in this to join us. We're going to be online next Wednesday on Reddit, Carlos Morel and I, and some of the authors, for what's called an AMA, Ask Me Anything. So we'll be online next Wednesday, 1 o'clock. It'd be fantastic if we could get all of you online with us, posing your questions, and we will answer them. And lastly then, why is health innovation so important? I am going to argue that it's important for at least 3 reasons. Firstly, and I have to say, I've had to undergo a sort of personal awakening on this. I tend to be a sort of kumbaya, huggy, fuzzy sort of a guy who thinks that mortality reduction is all sort of cross-sectoral, and we should obviously work with different development sectors, and we should all hold hands, and it should be this process where we, over the next 4 or 5 generations, we sort of build social capacity and political engagement and educate everybody. All of that is completely true, and I still believe it in my marrow, but the data suggest that the very, 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 very most important thing that you can do is to deliver health tools and health technologies. So that's been a real awakening for me. The second reason that innovation is so important is it's one of the most, perhaps the most effective way of stopping people from going into medical impoverishment, something I'm also learning about. And thirdly, it has tremendous economic returns. So investing in delivering health tools really is, it's the most expedient, the most rapid, the most powerful way to stop people dying. And I need to stop being embarrassed about that. Sometimes in the health sector we can be a bit embarrassed by saying, you know what, actually, it's the health sector. Really, it's the health sector. It's great that we're doing these other things. Of course we've got to do these other things. But what we really need to do to stop women children dying quickly is to get them health tools. And I want to just quickly tell you 3 stories, or rather 3 studies that I think tell the story. The first study comes from 60 years ago. It's kind of hard to believe. The very famous demographer Kingsley Davis, who was looking at the reasons for mortality decline since 1940. It was published in a paper he published 16 years later. And he talked about the great reduction in mortality in developing countries brought about mainly by the discovery of new methods of disease treatment, applicable at reasonable cost, and by the diffusion of these methods. This reduction could be rapid because it did not depend on general economic development or social modernization. It's a great lip service, he said, paid to. Very important to lift people out of poverty. But actually, the truth is, many of these scourges can be stamped out, none of this. The second study, I think, is maybe the most important study ever published, but it was published in a journal that I had hardly ever heard of, called the Millbank Quarterly. I'm sure somebody's read it before, which seems a shame to me, because it is so incredibly compelling. They examined 4 low-income countries that have reduced their mortality rates, their child mortality rates, at rates greater than would have been expected from their economic circumstances. So that's Bangladesh, Ecuador, Egypt, and Indonesia, all managed to reduce their youth their under 5 mortality rate by at least 40% over the course of about a decade. This is what they found. There were two factors that were explanatory. Targeting packages of selected health interventions to those who needed them the most. The interventions varied by country according to what the burden of disease was. So in Bangladesh, for example, a lot of it was about vaccinations and family planning. And financial and technical assistance for that scale up. Money and technical assistance to scale up those interventions. And get this. These mortality declines occurred even when there was poor governance, tons of corruption, violent political change, a lack of political will, and poor participation in the political process. Economic growth, poverty reduction, and reducing economic inequalities hardly contributed at all to the decline in child mortality. What mattered most, by far the most, was getting the right health technologies to those with the highest disease burden. And here is a picture that I have to say, maybe I'm just a very sad person, but when I saw this picture, it's coming out in the Journal of Health Economics report, I thought, this is a picture that in this community we need to be sort of singing from the rooftops and letting people kind of know about this, because I think it's utterly stunning. It's utterly stunning. I couldn't quite get my head around it. I presented it at the Gates Foundation recently, who has some very interesting questions, which maybe we'll have time for, maybe we won't. This is a paper coming up by Dean Jameson and colleagues, Martin Sandbu and others, studying what caused child mortality decline from 1970 to 2000. Very great variations across countries. 80% of it was from the delivery of health technologies. 80% of the decline. 9% from education of females, extraordinarily important to do, obviously. 8% from more doctors, only 3% from economic progress. I think that's the most stunning picture I've seen in a very, very, very long time. In fact, countries that adopted new health technologies, the rapid adopters, they saw an additional 2% per year fall in their child mortality over countries that did not. That is a stunning, stunning advantage. Secondly, it provides financial protection. 150 million people pushed into poverty every year, around 40% of households having to borrow or sell their assets. And there is a whole new way of studying the value of health technologies. I'm not an economist, but I'm slowly learning about this new tool called extended cost-effective analysis. It's cost-effective analysis, but it's being extended so that you don't just learn about the health gains per $1 million spent, but also the number of poverty cases averted per $1 million spent. And you see the distributional consequences. Who is gaining the most? Is it the poor or is it the rich? And these ECEAs, as they are called, are starting to show us something really profound. This, for example, is Stefan Vergey's work on HIV protection, HIV interventions, HIV treatments. They avert a huge number of poverty cases, mostly concentrated amongst the poor. And as these ECEAs come out, what you're starting to see is interventions like, for example, rotavirus vaccination have an amazing financial protection effect, largely through averting hospitalization. And actually some public policies like tobacco taxation, incredible financial protection effect, protecting the poor from medical pauperization of illness and hospitalization. And lastly, the economic returns to doing this are wonderful. Larry and I had the fortune of writing an editorial recently, which we called, obviously you can tell our point of view, the astonishing returns of investing in global health R&D, and we pointed to a recent study done by Jameson and Hecht on the returns to investing in an HIV vaccine. And sure, we've been spending almost $1 billion a year, and people will be like, wow, that's a lot of money, God, this can really be that cost effective. What are you doing, you people in the vaccine community? They find that assuming there is a vaccine of 50% efficacy by 2030, and most vaccine researchers actually think that's a conservative estimate, every dollar invested is going to return you up to $67 back. So the returns are absolutely profound. And yet, we are massively, massively underinvesting in R&D and in some of these other so-called global functions of global health. My team last year in a paper in the Lancet, we actually took a sort of 1 year of all health aid. We looked at the databases that track health aid, and we tried to quantify how much health aid is going towards the provision of global public goods, like R&D, the management of cross-border externalities, like pandemic preparedness, and global leadership and stewardship, the three so-called global functions of global health. We think it may have been the first attempt to do so. Certainly there are brilliant analyses of how aid is broken down by disease or recipient. We think it may have been the first effort to try and look at it by function. And what we find is that in 2013, only about a fifth of all aid is spent on these so-called global functions. So, for example, only about 3 billion, I mentioned earlier, for R&D for diseases of poverty. We certainly needed doubling. Under 1 billion for managing cross-border threats, even though, again, conservatively, the World Bank thinks we're going to need to triple that or quadruple that to have a serious pandemic preparedness system. So thank you very much. I will leave you with, again, encouraging you to join me and Carlos and Rel and some of the other authors on Wednesday, and I have time for just maybe a couple of questions before I run off and keep your relationship with the Gates Foundation very nice. Yes! Oh,
So I thought I would just cut to the chase and right at your brand.
Fantastic, great, excellent.
And we'll do it public.
It's a proposal stage still, so we bought you lunch already, didn't we?
So back in 2000, 2001, the WHO Commission on Macroeconomics and Health recommended two things. One was a global fund to procure drugs to treat HIV and malaria, and that happened. The other was a global fund for R&D. So, this debate about the need for what you described has been going on for some time. So it's really interesting data and information you're presenting, but it's not a new concept to increase that. So what's the problem? Is it all just lack of political will, or where's the problem reside?
I mean, it's a great question. There are obviously, it's true that the underspend has been going for a while, right? The so-called 1090 gap. 90% of all R&D being spent on diseases affect us in the world, etc., or the other way around. There is some new thinking about global treaties, for example. So you have Yolani Rottinger and his team saying this isn't going to go away until governments formally commit, whatever it might be. 0.015% of their GDP is a typical number. That treaty has, I would say, not necessarily gained steam. I'm not sure it has legs. There are some countries that are not so keen to trust the treaties, but clearly we're going to need, we're going to need innovative ideas for getting funders to the table. As we heard this morning, particularly for industry, the funding has got to come from the public sector and philanthropy. It's not going to come from industry. We've done better. 3 billion per year is way better than what we were doing 10 years ago. If you look at malaria R&D or HIV R&D. So the trend is good. My group spends its time now. I mean, some of this work of ours is new and we're still kind of road testing it and road showing it. We, for example, will be presenting at the World Innovation Summit for Health in Qatar at the end of the year. Some new data again on returns to investing in health and in health innovation. We will be reaching out to individual ministers, so we've got ministerial briefings lined up. But it's a great question. I mean, there's a whole political economy and resource mobilization for global health R&D piece that seems to be missing. Maybe there's a smart student in the room who can take that on. No? I've got time for one more. No, I don't. Yes, one quick one. Yes.
Actually, I think that one of the most promising would be the government funding of clinical trials on a global scale, rather than dealing with the research as such, which I'm very skeptical of. The actual covering the costs of clinical trials would bring down the cost of the results of products and make them more deliverable.
Yeah. That's true. Good, I'm going to run.
We're gonna have a slight switch.
I'll definitely say that. So I think that's a lot, so we make sure you don't have an ads, but I'm like, what else should I
Okay, so, we're just swapping Mike Corella and Joe Larson. Joseph Larson is the Deputy Director of BARDA. I should say acting Deputy Director, I guess, okay, the Biomedical Advanced Research Development Authority. He's previously served at BARDA as the Deputy Director of, how do you say that, CBRN, Medical Countermeasures, and as Branch Chief of the Broad Spectrum Antimicrobials Program. The goals of BARDA is the Broad Spectrum Antimicrobials Program, which I'm sure you're going to share with us, and enable the U.S. government to acquire medical countermeasures to protect the American public against virus threats, and to develop additional antimicrobial treatment options needed to counter the growing threat of antimicrobial resistance and clinically prevalent bacterial pathogens. Previously, Dr. Larson served as a senior science and technology manager of the Joint Science and Technology Office for Chemical and Biological Defense within the Defense Threat Reduction Agency. Dr. Larson was an American Association for the Advancement of Science Fellow at the Department of Homeland Security. There he managed university-based research programs aimed at the development of enhanced food safety detection systems and medical countermeasures for agricultural threat agents. There was a 2005 National Academy of Science Christine Mirzayan Fellow with the Board of Life Sciences, and he received his PhD in microbiology from the Uniformed Services University of the Health Sciences and his BA with honors from the University of Kansas. Thank you for joining us.
I wish I could still say go Jayhawks this year. So thanks for having me. Thanks for the conference organizers for inviting me. Pleased to be here and share with you BARDA's thoughts on incentivizing medical countermeasure development for emerging infectious diseases. So a little bit by way of overview, I'm going to shamelessly plug BARDA, and then I'm going to shamelessly plug our antimicrobial program. I'm going to talk about the experience that I've learned over the last 5 or 6 years on having policy discussions related to economic incentives for antibiotic development. In my opinion, there's a lot of parallels to that discussion, to the discussion around incentives for emerging infectious diseases. There's also some unique opportunities present within the realm of emerging infectious diseases. I will go on to discuss economic incentives for emerging infectious diseases, but I want to be very clear that these views are just thoughts. They're preliminary views on models to simulate emerging infectious disease. I gave a talk about, I think it was probably April 2014 at an Institute of Medicine meeting, talk very similar to this, and all of the companies that we had given stockpile contracts to, I think, pulled out pitchforks about halfway through this talk and wanted to rush the stage. So these are just thoughts, they're not policies. So for those of you that aren't aware about BARDA, in the most basic terms, we're the government-backed venture capital firm to support pharmaceutical development, vaccine development, diagnostic development for public health emergencies. We're located at the O'Neill Federal Building in Washington, D.C. If you're ever in the area, please stop by. Our goal is to support companies and remove barriers to developing medical countermeasures for bioterrorism agents, which we call chemical, biological, radiological, nuclear threats, pandemic influenza, as well as emerging infectious diseases. We go much further, though, than just simply providing companies money to do activities. Over the last decade of our existence, we have developed what we call the National Medical Countermeasure Response Infrastructure, which is a series of core services that we offer to companies, and that comes in the form of subject matter expertise and technical guidance that we give our companies. It comes in the form of regulatory and quality assurance advice and procedures. It comes in the form of a non-clinical development network, a clinical studies network, that any of our offerers, independent of whether or not they even have a contract with us or a partnership with us, could help tap into to advance the development of their products even further. sweet spot of where we tend to focus our development is between phase 1 clinical development and approval. That's where the majority of our funding exists. I will say in total in FY16, including our procurement contracts, our current funding for this year is approximately $1.4 billion, and that's divvied up along a number of different areas. We do have a fund that's called Project BioShield that allows us to procure products and stockpile them in a series of sites around the United States called the Strategic National Stockpile. We also have a fund that's dedicated to what we call advanced research and development. We use that to support companies and support their activities to de-risk their products so that they're positioned for a potential follow-on procurement. However, due to external events, we increasingly find ourselves encroaching further and further back earlier in development when we're called upon, not only by the American public, but by Congress and also our interagency partners to assist in responding to real-time events. And 2014, 2015 caught us very sternly in the wake of the Ebola outbreak. We teamed up together with our colleagues at NIAID and DoD to support a number of different programs that were discussed here today, and we're able to advance them from basically preclinical development into clinical trials in West Africa in about 9 months, which is good, not good enough. And we're working at ways of thinking about, and this is part of akin to the discussion that we're going to be having today, of what are ways that we can do that we can shrink that window in a way that makes a lot of sense and does so in a way that's cost effective. Also, we've been involved a little bit in MERS coronavirus in that space, and this is particularly a shameless plug I want to put in here. And actually, just recently with Zika virus, I want to point out some work that we did 2 weeks ago. The FDA basically directed Puerto Rico to stop using its own blood collected domestically within its internal populations, and that basically, because of the threat of Zika virus, that put the blood supply at risk in Puerto Rico. We were able to step up and award contracts to the American Red Cross and American Blood Services within 6 days within the government. That's pretty rapid. And we were able to collect blood domestically within the United States and ship it into Puerto Rico to ensure that there was no interruption of their domestic blood supply. So that's who we are, that's what we do. And so I call this the BARDA model, right? And so the BARDA model is used to address things when there's a market failure. And originally, when we were conceived, that market failure was born out of the anthrax attacks that occurred in the early 2000s. And in that instance, there was nobody that was developing anthrax medical countermeasures, or medical countermeasures really in general, that were doing it in a way that was going to allow them to get approved and get licensed. So Project BioShield was created, the Advanced Research and Development Fund was created, and we now have a robust pipeline of medical countermeasures for bioterrorism agents. We've been able to stockpile 15 products for emergency use. And similarly, in 2009 with the H1N1 pandemic, there was a market failure in the sense that vaccine developers only make enough vaccine to support the seasonal influenza market. So when there's an actual pandemic, we need to ramp up production to support that need globally. So we stepped in, increased our domestic influenza vaccine manufacturing and production, increased that scope and scale globally, and helped step in to address that market failure. Both of those collectively have led to 24 products being FDA approved in the decade that we've been in existence, which I think is on par with any small or medium-sized pharmaceutical company. I've been personally involved more directly with our role in antimicrobial resistance, which we also define as yet another market failure for a whole different series of circumstances that we'll discuss. But I created BARDA's antimicrobial program in 2010. Since then, we've been able to advance 4 candidate antimicrobials into phase 3 clinical development. And we could go on down the line and talk about in each one of these different instances whether there's a market failure. But the unifying theme here is that the BARDA model is one that can be used to help address these failures. This is BARDA's antimicrobial portfolio. I'm not going to spend a line talking about this, but one of the things I wanted to point out in the next couple slides are ways that we've used innovative partnerships to help spur innovation in antibacterial drug development. And one of the ways that we've done this is by establishing partnerships that exist in the R&D space that allow technical attrition to occur. And this was born out of an experience that we had with GlaxoSmithKline. And originally, we had funded them for a molecule that was supposed to be a novel, gram-negative, hospital-acquired infection antibiotic. It was going to be the first one of those in 40 years. And we were absolutely excited about it. It took us about 18 months to negotiate that contract. Then about 3 months in, it tanked in phase 2 clinical development. And we all kind of looked at each other as the smoke was clearing and say, how do we not have this happen again? Because now we would have to go back and start that process all over. And so we came up with the concept of a portfolio partnership. And this uses a type of an agreement within the government that's called other transactional authority. And this is something that was born out of DARPA, was the one that originally had this authority, and we have it in our enabling legislation, and we never used it. And so I convinced the powers that be that we needed to. And it basically established a 5-year, $200 million public-private partnership with GlaxoSmithKline. And it's independent of any one molecule. So if something looks like it's going to fail and it fails, we kick it out of the portfolio. If there's something that's come up through their internal pipeline or something they want to in-license in, we bring them in. And we manage the investment of about approximately $40 million per year over those assets in real time. It's a joint decision where it's a collaboration between us and GSK where we both sit at the table and make these decisions about how that money is going to be invested. They also have money invested in this as well, so it's a cost sharing. And what we found in the wake of awarding this agreement, we actually had a number of companies contact us and say, you know, if I could get one of those, we would get back into doing antibiotic R&D. And that's one of the things that we would like to see is an environment where barriers are removed to people wanting to come back in and innovate. That was the first one that we did. Our second one that we did was in 2015. And I won't spend a lot of time about it, but it's almost identically structured, and it's with AstraZeneca. And that's the first initial one as a phase 3 ready molecule in it, and it's supposed to support the study, the phase 3 clinical study of this trianam avibactam to treat drug-resistant gram-negative infections. Another interesting aspect of this is that we were also able to collaborate internationally with the European Union's Innovative Medicines Initiative program, and they're actually supporting the European trial sites for the phase 3 clinical trial, and BART is picking up the non-EU sites. And I think this is also another kind of example of the type of partnerships that are going to be needed to engage on emerging infectious disease, where we just don't talk about partnering, we actually put money on the table and actually leverage it so that we're both achieving a common end and a common goal. Another type of innovative partnership that we're getting ready to create, and I'm excited to share with you all about it, is the concept of creating an accelerator specifically for antibacterial drugs. And an accelerator, it typically is a fund that gives companies money, tends to take an equity stake, and then advances their products in development. This will not take an equity stake, but will basically provide a third party, and that third party we're envisioning as a nonprofit, an existing life science incubator or an accelerator, who will then go out and make investments in collaboration with both BARDA, and I will mention that our colleagues at NIAID are joining forces with us on this, to go and invest in preclinical candidates to advance them into first time in human. We went out into the market and we asked the antibiotic developers, where is the hardest spot for you all to raise money? And they indicated to us that right at that spot where we have initial data showing proof of concept to getting into first in human, because that's where the most risk is. And so one of the things that we want to do in approaching this is we want to, again, remove any barrier to any company who wants to develop an antibiotic. Ultimately, my vision for this is that this becomes basically a global innovation fund for antibiotic development and discovery. And there's no reason once this architecture is created that anybody else, foreign government, not-for-profit, any of those other things could come in and invest with us, get a seat at the table, and make these kind of joint investments in a coordinated fashion. I bring this in the context of emerging infectious disease because there's absolutely no reason that this architecture could be recreated or adjusted or modified in some way to support a preclinical portfolio that could rapidly be redirected to address emerging infectious diseases. So, there hasn't been a lot of talk about incentives today, but I thought it would be important because that's kind of where I'm coming to from this, is to kind of give you a sense of incentives and give you a sense of where conversations are headed in other areas related to incentives. I wasn't sure who was going to be in the room, so I'm giving the basics. So a push incentive, you'll hear me talk about that, is something that basically subsidizes the research and development costs. It pays for outcomes or pays for research, whether it's successful or unsuccessful. Okay, so an example of that is a grant, product development partnership, a tax credit. Then there's pull incentives, right? Pull incentives would be a market commitment, a milestone or prize payment that occurred after successful development, a transferable patent voucher that was generated at FDA approval, additional market exclusivity. In terms of antibiotics, there's an interesting topic and line of thinking that's being discussed, and I think it is applicable to emerging infectious diseases. So it's important to note that antibiotics are the only class of drug in existence that the more you use it, the less effective it becomes, right? And And so it doesn't make a lot of sense for us to have a model where profitability is driven off of how much you sell and therefore by proxy use of that product. So there's an emerging theme in the field of antibiotics is that we should look to what's called a delinkage model to support antibacterial drug development and ensure its profitability. So these are models that delink profit from units sold. And so the idea here in one model is there's two different variations on this. One is a full delinkage model, which I think is a little more idealistic than what I think could be achieved, is where a company gets drug FDA approved, the government basically gives them a ton of money and then basically buys out the IP and then goes from there. I don't think that's really a feasible option. We actually favor internally within BARDA what's called a partial delinkage model, which is that company develops a drug, it gets FDA approved, it gets a payment, right? But in the US, drugs are approved on the basis of non-inferiority. So it's just as good as the last thing. So we don't want to give it all the money, but then we would want to put in some sort of metrics and milestones beyond that that would allow them to achieve and make sure that they actually obtain a robust return on investment so that we can say, thank you for innovating. You just made a new antibiotic. Here's whatever amount of money that we think is just. But it's going to be hundreds of millions, if not $1 billion, to that company to say thank you for innovating and ensure that they have an appropriate market. Under a partial delinkage model, the company would still be able to sell. But I think one model would be as a condition of those payments, terms and restrictions could be established. For example, you can't market your drug. For example, we could negotiate a sales ceiling that if you sell over a certain amount, you no longer qualify for those payments. If you sell over a certain amount, you have a market, you don't need us anymore. So I already talked about this. Push subsidizes general development, pull rewards successful development, and delinkage we've covered. So case study around incentives for antibiotics. Incentives have been widely discussed for about the last decade related to antibiotics. And in general, through NIH, through BARDA, through IMI in Europe, push incentives have largely been implemented throughout the entire phase of development. However, they could be expanded, meaning you could give us more funding to do more with that funding. The only incentive that currently really is in existence that's been passed in the last 5 years is the GAIN Act, which provides, I think it's 5 years additional market exclusivity for antibiotics. And if you look at the calculation of what that means, additional market exclusivity is really a weak incentive. It doesn't really do much, and all it does is pass those costs on to the patient. And at the end of the day, though, it still is a positive thing because at least Congress is talking about this and they're doing something. We think delinkage models could be an effective pull mechanism. There's a lot of discussion about this going on in the UK and Europe. As of this week, Secretary Burwell directed the Presidential Advisory Council on combating antibiotic-resistant bacteria to take on economic incentives. So it'll be very interesting to see what comes out of that group related to this, but that's certainly a policy. But we, as a government, have not taken any position on an appropriate suite of incentives for antibiotics. But when we think about incentives, and whether we're thinking about incentives for antibiotics or whether we're thinking about incentives for emerging infectious disease, incentives need to improve something called net present value. Okay? And the net present value is computed, at least, by calculating the sales less cost for each year, so your annual net cash flow. And each future year's cash flow, which you need to discount that value because $1 today is worth more than $1 5 years from now. And you calculate the total across all years of your potential development, factoring in technical attrition and the risk of development, and that is your net present value. So how do incentives improve that? Well, push incentives improve it because they lower your R&D costs, which inherently would raise your NPV. Pull incentives improve NPV because they're putting a carrot out there at the end of development that you know if I'm successful and I innovate, I'm going to get X, or I'm going to get Y payment. And both of those things factor into an NPV calculation. And there was a report that was commissioned by a sector of HHS called ASPE that is available on the link below that examined the NPV values for antibiotics based upon common body site indications. This is hospital-acquired bacterial pneumonia, complicated urinary tract infection, community-acquired bacterial pneumonia, on and on. And basically what that says here is that for some indications, like hospital-acquired bacterial pneumonia, where frankly we need the most new antibiotics right now for, the NPV value is actually a negative number. So that would mean that if you're sitting around, you're the CEO of a pharmaceutical company, and somebody comes in and says, hey, it's going to take us 15 to 20 years to develop this, and guess what? Right now, we're going to lose $30 million. It's a non-starter, right? And these other indications, while positive, community, let's take the best one, community-acquired bacterial pneumonia at 37 million. You're gonna make $37 million and you're gonna spend 15 years of your company's resources doing that, when you could make the MPV value for a cardiovascular musculoskeletal drug is 700 million, a billion. It's just not sustainable. But yet, society, views these drugs as a much more valuable proposition. If you look at the scales on this graph where it goes up to 40 million, and the scale on this graph where it goes up to 200,000 million, whatever that number is, that's the value that we place on being able to treat these bacterial infections. So there's an extreme disconnect here. I also think if anybody wanted to work on this, it would be an interesting project. Would be go look at the NPV for what a medical countermeasure would be for an emerging infectious disease, right? But then flip that and say, well, what is this? What value would society place right now on a medical countermeasure for Zika? What value would a pregnant woman that's been exposed to Zika place on that medical countermeasure? And so when you consider MPV and you consider the role of antibiotic development, basically you're negative all the way through discovery, and then you dip even down lower when you get into phase 2 development because each one of those studies costs $60 to $80 million each. And then you launch. Antibiotics are launched terribly because when you launch a new antibiotic, that's the last thing the doctor wants to use. It's going to use everything else before to preserve the value of that antibiotic because we're now in a model where use is tied to lessening efficacy. And so if you calculate this, and this was done by basically a different analysis, is that at the end of the day, at the end of your launch, you're still basically at a loss of around $50 million. And so again, if you look at this from the lens of emerging infectious disease, you're going to spend all that money doing the development, and then there is no guarantee of a launch, right? Because you don't know if the disease is going to emerge or not, or if it's going to go away in a year after So just real briefly to plug something we're doing through the Transatlantic Task Force on Antibiotic Resistance. We have reviewed every single policy document that has basically come out in the last year or two. And this was thanks from WHO, thanks from the President's Council of Advisors on Science and Technology. Lord O'Neill, who's the former CEO of Goldman Sachs, did a review for the UK government, on and on and on and on and on, and tried to say where there was commonality in these policy recommendations. So I think this would be interesting. Project number 2 would be if somebody went out and said, what are we all saying is needed and would work for economic incentives for emerging infectious diseases? And if there actually is I actually think there's actually probably a lot of commonality there. And then thinking about synthesizing that in a way that's cogent would be interesting. What we found, and I think what we're trying to do is we're trying to rally the rest of TAPFAR to get behind this and sign on as authors for this, and we're going to try to submit it for publication. But what we found was there's an immense amount of consensus. And in fact, many of these papers are serving as kind of an echo chamber, bouncing off of each other. But both push and pull incentives are recommended, and so we agree a constellation of incentives are going to be needed, and there's a constellation of incentives that are going to be needed for EID. Delinkage was almost uniformly recommended in these approaches, and we agree. And also there was the idea of a global funder and a global threat assessment. Global threat assessment seemed to have a little bit more consensus, and global funder was a little bit more shaky. And I think that's going to be the challenge here with emerging infectious disease. If people really want to share resources and kind of come up with a common way of coordinating these things, that's not easy. And that's what people's reluctance is here, is that they're going to lose control over their investment, and that's one of the areas where I think people have, they're a little less comfortable. So incentives for EID, this is kind of more of the thorny part of my talk. So again, these are thoughts, not policies. So factors affecting incentives for EID, right? What we've learned through Project BioShield and stockpiling multiple products for, right now we've got over 1 million treatment courses of a smallpox antiviral stockpile. And we're sitting there going, man, that's a lot of money. And eventually this stuff's going to expire, and we're going to have to buy more of it. And that's fine, and I think that's an appropriate model for things that we have deemed to be a national security threat and the things that we've deemed to be a material threat to security of the American public. It's a totally valid model. But for things like this, for things like emerging infectious disease, when we don't know whether or not the disease, that we need to be prepared, that we need to get to some point in preparedness that seems to make sense, but have it be sustainable, so that because we can't stockpile antibodies for Nipah virus or antibodies for monoclonals for Hendra virus. Those things have emerged before, right? And it probably would be of value, but it's not going to be cost effective for us to do that. Again, like I mentioned, some diseases emerge, then explode, some don't. And every time that we respond to one of these, it is a multi-$100 million affair across the government. It spent billions of dollars. The appropriation for Ebola was like, I think, $9 billion, you know? We didn't spend all of it, but it's been allocated, and we spent a lot of it. And there seems to be a desire that it's okay to pay for responding to this and not pay as much to prepare for these things. And I think there needs to be a different model articulated here that actually is favoring cost effectiveness in all of this. There's also a complete uncertainty. Our ability to determine whether or not the disease is going to emerge is completely ineffectual. We need better predictive tools. That's not the focus here. But even I think if we had predictive tools, I think we still would have missed Zika, you know? So we also need to figure out a way to reward innovation. We want to congratulate our industry partners for being successful. We want them to feel they're operating in an environment that has reduced risk, but we need to do so in a sustainable fashion. And that's really the challenge here. So the experience that we've had to date with pull incentives have focused largely on stockpiling. Okay? So we've stockpiled things like raxibacumab, which is a monoclonal antibody for the treatment of anthrax. It's great program. It's worked really well. We've also used vendor-managed inventory. So Neupogen and Leucine are two products that can treat the hematopoietic effects of being exposed to ionizing radiation. These are cancer drugs. So what we negotiated with the companies is that they own a specific bubble in their inventory, and they always maintain that surplus. And as product is rotated out into the commercial market, they backfill it through their own supply. So we're guaranteed that our preparedness is met through their inventory, so we don't have to stockpile. That's a great model, but it only works for things where there's a commercial market and there's clinical use, right? I will stop and say here that because people have presented on a number of different Ebola vaccines today, we still have requirements for Ebola therapeutics. We still have requirements for Ebola vaccines because they are also viewed, in addition to a public health threat, as a potential material threat to the United States. And so we still have plans or intention, depending on the availability of funds, to stockpile those products. So what are some alternative models that we can think about in determining where to stop in development and reward innovation, but allow to do so in a little bit more of a cost-efficient fashion? And one of the things that we think about is for CBRN pathogens or programs before, at the point where they're basically allowed to be stockpiled, they've achieved something called pre-emergency use authorization status. That basically means that they have data in humans and about 300 people for safety. You know how to manufacture the product in a validated and robust fashion. And if there's an animal model, which for CBRN threats there typically is, you've generated data in that animal model that is suggestive of efficacy. If you've met those three criteria, you're generally allowed to be stockpiled and stockpiled for emergency use. I don't see why that point in development would not be a logical point to cease development if there was no ability to conduct a randomized controlled clinical trial, right? And that's where we find ourselves with almost all of these pathogens that have emerged and then have de-emerged and haven't spread globally. You know, that's how we would basically handle something like Ebola right now. And what I would think that we would do then is we would reward the industry partner for reaching that point. We would give them a milestone payment and say thank you. And then there would need to be discussions about who was going to own and store that product in the case of an emergency. And I think that product could be transferred to the government. The seed stocks, the cell banks, and the tech transfer material could be transferred to the government for them to hold. And then we could have the right to, in the event that there was a global outbreak, we could then subcontract it back out to the company or subcontract to our own vendors to begin ramping up production and development of that product. Another model that's been talked today in the context of the BPO, but let me be clear, I'm not endorsing a BPO, I'm just saying that this type of model potentially would work. We kind of call it a fee-for-service, which is that we can enter into these type of strategic partnerships, other transactional agreement mediated arrangements with a select number of partners that had a platform technology. And whether or not that platform technology was related to vaccines, whether it was related to drug screening, whether it was related to monoclonal antibodies, we can establish those partnerships and then basically, while there wasn't an emerging infectious disease, work on priority pathogens we thought might become one, get them up to that into phase 1 point in development and then stop and kind of just keep churning those things out as kind of, and then just continuing to pay our industry partner to do that for us. And then in the event that there was an emerging infectious disease, we could rapidly redirect resources through that existing agreement for them to start a more directed and robust effort against a disease that was imminently emerging. Now, there's a lot of pros to that. You're dealing with a known partner, dealing with a partner that has a multitude of capabilities. But on the other hand, instead of having companies come to you on an ad hoc basis and developing products up to a certain point, you're basically putting all your eggs in one basket. You're trusting a select few individuals to help establish this capability. And I'm not saying that's right or that's wrong, it's just a risk. And another model that we could potentially stand up with our existing authorities, but one I don't really favor, is creating a prize. That basically Marty could put out a list of 20, 30 pathogens, 40 pathogens that we wanted people to develop things for, and we could sit back and say, if you develop this and you get to this certain point, and again, I point to this into phase 1 state, that then we would pay you some sort of milestone or prize payment for doing that. The problem doing that with companies are going to tell you is that we don't have any money to subsidize our R&D costs. And so that would be a challenge. And then you would still need that follow-on infrastructure and that follow-on capability to be able to support scaling up in the event that there was an actual event. So while I put this on here in the sense of this is one thing that we thought about, it's not one that I necessarily gravitate towards. So I also think it's really important that when we think about these things, we think about them in terms of different case studies. And because each set of incentives that we're talking about here is a different set of tools. And a different set of tools is going to be required for a different type of situation. So first one is, what sort of incentives are going to be needed if you could actually conduct a clinical trial against a disease that is emerged? And I'm not saying necessarily you could do one against Zika, but maybe something like Chick or dengue. So that's kind of like, not the easiest, but the most feasible, and what sort of resources would be needed? In my mind, that would mean that you would just provide push incentives, and then if there's presumably a market, you could potentially sell that product, but there may need to be some sort of advanced market commitment to if you were selling it in the developing world. Then there's diseases that have emerged and were substantively emerged. An example of this would be like Ebola, but now they're no longer emerged. And so what sort of incentives need to be put in place there that may be different than the other case where you could actually do a clinical trial? Because right now what we're finding is that we tried to do a clinical trial with ZMapp, which is the monoclonal antibody cocktail. I should say NIAID conducted that trial, but we funded a lot of activities related to that. And because the standard of care improved as the outbreak waned, there's really no statistical significant difference. There's a trend, but it's basically data that we can't interpret. And so now we're stuck with going back to having to establish expanded access protocols to take the onesie-twosie patients and do work with them, and then we give ZMapp like we're doing now, because there's now little bits of flare-up. But that data doesn't get us to where we need to be. So what does their development path look like, and how can it be incentivized? Then there's a whole host of diseases, right, that have emerged, but now and then never went anywhere, right? And the ones I think about are Nipah and Intra. They've caused disease before, and they just haven't exploded. But is it worth us spending, I don't know, $75 million to make sure that if that were to ever happen, we'd be okay? I don't know. And there has to be a lot of discussion about prioritization and resources and where we ascribe value. And the last one, I still scratch my head on how you incentivize this, or put things in place. What do you do for the thing that you don't know is coming? And I think that's by far the toughest nut to crack. So, in sum, I hope I've imparted upon you some knowledge about alternative business models and how they're going to be required to incentivize development and ensure market sustainability. My view, the mix and push and pull incentives is needed. We've demonstrated that through Project BioShield. We've demonstrated that through a number of different mechanisms. For EID products, we're going to need to reward innovation in the face of market uncertainty. And in my view, conventional stockpiling for EID is not likely to represent a viable or sustainable model. And I do believe there is a role for international consortiums in cost sharing and helping us get to a point that makes sense in terms of coordinating our response to this. No, it's not easy to develop these things. There's a lot of moving parts, but I think, in my view, I think that's basically an expectation that people should have of us. So, my contact information is up here. If you have any thoughts on anything I've said today, please don't hesitate to email me or give me a call, and I'm happy to take a few questions. Thanks.
I'm a prize enthusiast, Joe, so I don't quite understand the critique that you've heard from some that, well, we don't have any money to get started with. That's what venture capital's for. This is a standard problem in biotech. If there's a prize, venture capital will give you some money now so they can share in the profits.
If the prize is large enough, maybe. But I actually, and I think they would say, okay, after the prize, well, then what? What are going to be your annual returns following that? Because venture capital, they're concerned about, they're taking an equity stake, basically. They want to see a return. And, I guess that my comment is born out of our experience with small companies developing things for bioterrorism agents, where it's the only thing, it's biotech, it's only going to work against anthrax. And what we've seen time and time again is that maybe at first there's a little bit of VC interest, but over time it becomes a situation where they're dependent upon the government for continued support. And my concern is that we would be engendering a model where we want to avoid that to a certain extent, but I also still think they'd be able to raise the money to do the level of R&D that's required to get these products to that point in development.
And I don't know if you can say, but can you give us a sense of the magnitude of the prizes you talked about, or is that not open for discussion?
So I can say for the partial delinkage model, and this is still where a company can sell it, right? But what we're thinking about here, so Acinetobacter baumannii, right? It's a severe gram-negative infection that basically kills you 50% of the time if you have it. But the level of infections right now in the United States is 5,000-6,000 infections per year. So it's really hard to do a clinical trial if you had an Acinetobacter-only antibiotic, but also your returns on that antibiotic would be extremely limited. So, but I think in general, people in the public health community would argue that we need an antibiotic. It would be beneficial to have an antibiotic that treated Acinetobacter baumannii. So in targeting things where there's very limited markets, there's going to be very limited use. I think we were toying with the concept of approximately a $500 million payment, and still allowing the company to sell the product. And if you were going after something like that, you potentially could charge a little bit more of a premium price because of the mortality benefit that you would be getting off of that.
Thank you.
It's a wonderful presentation and a wonderful record. I was just thinking as you went along, given the difficulty of downstream resources for the obvious reason, you might want to pay some more attention to pooling upstream resources where it's feasible and you need some push and pull as well. So, for example, there's a major project underway in Europe funded by the European Commission, a COMPARE project, where they're pooling data on emerging and re-emerging foodborne pathogen diseases and constructing an all-European database. I'm evaluating that. I've seen the first year's work. It's amazing what they've accomplished already, which would enable them already, just to take one thing, would quickly see the direction that the disease is moving and allow the people in the way to get onto it. And another pooling area that could be of enormous importance would be upstream genetic resources. An example we see on the table is the WHO pandemic influenza preparedness framework, but there are many other possible areas where that could be, I think that could be done, and might free up access to genetic resources that are currently under attack, either by too many premature patents in the north or claims under the Convention on Biological Diversity from the global south. The more of these pools that we could establish and make readily available to scientists, the more results we might have.
Oh, great point. One of the things I did not discuss here is all of the tools that we need to be supporting to help inform decisions about risk and decisions about predicting when we should be pulling this lever and when we should be, and how we should be prioritizing these things.
I thought the models you brought up for antimicrobial resistance were really interesting, both non-dilutive funding and the idea of biopharma incubator. But thinking about this in the context of emerging infectious diseases, there are other push and pull incentives in place right now, such as the orphan drug tax credit, the American Voucher Program, which can help subsidize the cost and serve as an incentive for the market. So how would you envision BARDA structuring those same models that you have for AMP or neurological diseases in light of these other incentives that already exist? How would they play into your decision process?
So, priority review vouchers, I understand it, that really only reward successful research, right? And the other one was the orphan drug, which is, there's a little bit of grant funding there, but it's a tax credit and then 7 years of market exclusivity.
Yeah,
Right?
it reduces the cost.
In my mind, well, I should say this, as part of the Obama administration's initiative on combating antibiotic-resistant bacteria, they asked us to form an economic working group that was looking at antibiotic resistance and what incentives the U.S. government would recommend to be implemented. And I can't talk about the specifics of the report because it didn't go forward, but what I can talk about is one of the things we immediately looked at was how could we just basically mirror the Orphan Drug Act as a way of incentivizing antibiotics. So I think that these things, it's a synergy issue, and you can add the non-dilutive funding and incubator to the orphan drug and to patent review voucher. You're just making the environment sweeter for people to participate. So that's only going to translate to increased innovation. And for antibiotics, we haven't had a new class of antibiotics to treat gram-negative infections in 40 years. about computers, think about any other major, think about oncology, right? And right now there's 28 drugs in phase 2 through 3 development for antibiotics and like 504 for oncology. So I think we have a long way to go to get to a point where people feel that we have a robust and vibrant pipeline for antibiotics. And I think we even have further to go in thinking about, ensuring that we have a degree of preparedness about any future emerging infectious disease. So I say throw a constellation of incentives at it.
So you talked a lot about monetary incentives, and I used to manage part of the stockpile programs at Novartis, so I did a lot of dealing with some of these initiatives in particular. But one of the challenges that I've seen for smaller companies and smaller biotech is some of the functional capabilities. So not necessarily contracting out clinical capabilities or contracting out manufacturers to help develop their technology, but also getting support or advising on how to navigate complex regulatory pathways. You have these really smart scientists, great ideas, but they have no idea how to move forward. So what kind of discussion has gone on within the government about providing some kind of technical consulting services or shared learnings across your different programs to help companies overcome some of these major challenges and milestones?
So first, I'm really fortunate to lead a team of really talented folks, many of which are our subject matter experts and have been in pharma for 20, 25 years. Many of those folks have regulatory and quality affairs experience. And every time that we support a partnership with a company, we form a team of experts around that. Maybe we'll have a manufacturing expert, a clinical expert, a regulatory expert, and all of those people provide direct back and forth dialogue and guidance to companies. And so for many of these smaller companies, they actually view it as a benefit because they just got 8 free consultants. And that's one way that we help navigate the process. I will say through our accelerator that we're going to be establishing, a major component of that is not just to provide money for activities, but it's also to have a suite of consultants on hand to be able to provide expertise. But it's also, in addition to technical assistance, it's entrepreneurial assistance. That, how do you stand up a management team? How do you go out and raise Series A funding? Because a lot of these companies that are just starting off have no clue. And about half the time, it's not, the company fails for reasons that are other than technical. And so, in other words, we see those things too, and what we're trying to do is think creatively about trying to provide those resources internally through BARDA to help them to help lower that risk, because their risk is our risk. I think we get kicked off. Thanks.
Let's do it. Can we get a board of grants for our partnership?
I have a big check out of my car.
I feel especially lucky to be able to introduce Mike Carilla today because the last time he was supposed to come to a meeting that I was running, he got suddenly called to the hill. So I've been waiting all day for him to suddenly get a stricken expression and rush off to Washington. So I'm happy he's still here. So Dr. Carilla is the Director of Biodefense Research Affairs for NIAID. His primary role is to provide overall institute coordination for product development of medical countermeasures against bioterror threats. At the University of Virginia, he was an assistant professor of pathology as well as co-director of the Laboratory of Molecular Diagnostics and associate director for clinical microbiology. He moved to the private sector working in anti-infective drug development at DuPont Pharmaceuticals, Bristol Myers Squibb, and Wyeth. He subsequently joined NIAID as a medical officer, and in 2005 he was named to his current position within NIAID. He received his undergraduate degree in chemistry from the California Institute of Technology, and here in his MD, PhD from Duke University. So he's come home. Welcome, Mike.
Okay, so the topic here is partnerships, and I'll start off by saying there is no perfect partnership. But interestingly, just earlier this week, I was on a panel with representatives from CAF and from Gavi, talking about partnerships. And it's very clear that depending on the developmental stage or what part of the process we're in, there's different needs, different requirements for partnerships and to move forward. So Joe has sort of set the stage that we overlap quite a bit, and I don't think there's a problem with overlap per se, because I think if you need a little bit of overlap to ensure that there aren't any gaps in terms of the development. But I'm going to talk about the very early R&D phase of in terms of partnerships. I'm going to talk about it in terms of what the public side of that brings to the table. A lot is talked about what do we need to do in order to get the private side in. But I'm going to talk about really what the public side can really offer that I think has a lot of advantages. Now, this is a listing of the kind of focus and capabilities at my institute, the National Institute of Allergies and Infectious Diseases, which is focused on obviously infectious diseases. Everybody understands that NIH does basic research. I think that's pretty much the bread and butter of what we do. There's a lot of discovery and early stage product development, concept identification processes that go on. Historically, I think 30 or 40 years ago, we were actually in a very different situation, and that is the basic scientists at Eureka in the laboratory and 4 or 5 pharmaceutical companies, because there were literally dozens of them at the time, we come running in and plop down and try to buy up the rights for that. That doesn't happen anymore. Discoveries don't necessarily engender that type of excitement on the part of pharmaceutical companies. They want to see a little more preclinical. In some instances, they want to actually see some early stage clinical development before they go in. And what has clearly happened in the infectious disease realm, because of a lot of reasons that have been talked about, you simply don't make a lot of money. They need a lot of de-risking. They need it very far down the pipeline. And at the NIH level, the moving into the product development mode is not something that has been the bread and butter of NIH. I find it interesting that, in fact, an inventory taken a couple of years ago prior to the institution of NCATS, the National Cancer Institute at my Institute of Infectious Diseases actually accounted for about 90% of all the translational and product development efforts that was going on at NIH. And I find it interesting because although those cancer and infectious disease are 2 diseases that kill people, they're also the 2 specific areas that we fight fire with fire. So we're the 2 groups that try to kill stuff. Everybody else wants to keep things alive. But for some reason, in cancer and infectious disease, there's a lot more interest in moving for investigators, even in the basic science, to try to move products forward because people like killing stuff, I guess, is how it works. And so with the abandonment of the pharmaceutical companies, as Joe has talked about in terms of antibiotics, and the uncertainty around emerging infectious diseases in terms of market share, we have felt the need to actually push further down the development pipeline, de-risking that to create more IP and more valuable key milestones that have been achieved to sort of de-risk the process going forward. The other point, the last point, is something that we've taken a much greater interest in, and that is a recognition that when you're talking about innovation in science and you're talking about innovation in healthcare, you're talking about new concepts, new modes of intervention. And those new modes actually create the need for new regulatory review of those types of processes. And the regulators need a comfort level before they have confidence in approving something. And so partly there's an uncertainty about moving forward on the part of companies because they're unsure how the regulators are going to actually look at this. And this is very difficult for any single company to take on their own to establish that regulatory science base upon which their new product is being developed, because it's very expensive, it also is very complicated, and it also lengthens the timelines of development. And so we have taken on working with the FDA, in partnership with the FDA, to try to identify what are some of those issues that the regulators would like a little more science behind, so they feel a little more comfortable looking at these new types of innovative modes of intervention. Now, there's a lot of terminology that gets thrown around. This is what I use. Everyone, I think, understands what basic science is. Translational components, which is going to be which is a fair bit of our bread and butter of what we do in terms of moving product forward, is really where we're trying to exploit a concept. We're trying to take those discoveries and really see if we can actually convert them into some means of intervention. And if we can, then we begin to look for a product. Product development is where we really into the mode of testing for a candidate. The sweet spots for us is how far we want to carry something is through phase 1, get it into phase 2, and that's when we're looking for a transition. And you'll see on the slide later on, BARDA is one of my transition partners. The bottom line is that from NIH's standpoint, we're never going to manufacture, license, and distribute a drug. We're not a pharmaceutical company. We don't want to be a pharmaceutical company. And so to carry the products forward, we do have to have a partnership of some type for a partner that in the end we can hand off to and let them carry on with the downstream activity. Now, the problem is when you get out of the realm of basic science, pure basic research, the problem is stuff never looks as exciting, as elegant, as sexy as what the really hot, hard-hitting basic scientist is doing. And so when you have something as banal as stability or formulation studies of a vaccine that have to be done compared to a really hot, exciting area of science, it's very clear what the reviewers are going to think is the best thing to do. So in order to be able to compare apples to apples and not do an unfair comparison, we've actually created different types of funding mechanisms so that we can separate these out. So the grants largely cover the basic science portfolio. NIH has historically had the small business, the SBIR, we're obligated to allocate a certain percentage. And it's not an inconsequential. I think the number is up to about 3 or somewhere around 3.2% of our total grant pool that we have to allocate for small businesses. But it's simply not enough to really carry things forward. So we've created a partnership program that really is geared towards translational science. And what we typically find is these are generally a small company and an academic who have gotten together to try to really move a product forward. They generally do not carry you through into clinical development, but generally will go up to as far as IND submission. And then when we're really focused on a real product, when we really have an expectation that we're going to take, we want to see that product go as far as we can, we generally use the contract mechanisms, and it's very targeted to what we're going after. So, but the funding out to investigators of any of these types is simply not enough. We recognize that that's not all it's going to be. On the one hand, these types of solicitations, even initiatives that we put forward with funding plans associated with them, they're very long. There's long planning. It takes a long time. You submit an application. You have to get reviewed. You have to make the award. It can be upwards of a year after you've really assembled that proposal. And so they're not as timely. And so what we've done is to try to create what we refer to generically as critical infrastructure, a wide array of services that we can offer to the community. And that's the academic, it's the small business, it's even large pharmaceutical companies who can take advantage of specialized needs that they may have. And it could be something as simple as sequencing. We maintain a very large repository of strains and reagents. We have animal model development. I'll show you some of this later on. We have a lot of product-related activities where we can do preclinical and clinical drug and vaccine testing, animal testing. Then we have clinical capabilities to actually do primarily phase 1s and phase 2s, but phase 3s if necessary. Now, over the years, we've assembled a wide array of services that run the gamut from in vitro assessment of something that an investigator thinks they may have. It may be an academic who has hit upon some particular set of compounds that they'd like to have tested. It may be a company that is working on a particular class of compounds that they're focused in one direction, but they've gotten some indications that maybe there are additional clinical indications that they might be able to seek. In some instances, what we make available here, although it's across the entire infectious disease spectrum, things that would otherwise be very difficult for even large companies to be able to do. Things that require BSL-3, BSL-4 containment, select agents, if you're working with those. We heard about the work earlier with the companies with Ebola vaccines. If you're going to test your vaccine in a non-human primate, you have to have access to a BSL-4 lab. You have to be able to have that lab has to have select agent registration. Companies are not in a position to really do that. They have to go somewhere and have that done. We make that available since 2010 when we instituted this a service of non-human primate filovirus vaccine testing. We have since 2010 tested over 50 different vaccine candidates for companies and academics. About a dozen of those have advanced into further development, and I think 9 of the 12 that have actually gone into clinical development have gone through this testing. But it's a wide array of other types of things. The interventional agents pretty much do anything that would be IND enabling required by the FDA. Biopharmaceuticals is to handle biologics such as monoclonals, and then in vaccines we do a wide array of testing, as I mentioned, for the field, but a lot of others as well. We have manufacturing, assay development, and then clinical. We have a series of phase 1 units and vaccine treatment and evaluation units. Underpinning all of this is a wide series of animal model contracts that allow us to do both a combination of animal model development. Zika is a good one in mind because obviously there were no animal models whatsoever. So through this contract, I can immediately go out, which we have, and initiated development of animal model contracts that would be used for both a study of the virus pathogenesis in terms of infection, but also to evaluate small molecules and potential vaccine candidates. And that gives us a flexibility to move very quickly and move forward. So I want to give you some examples of where we've had some partnerships in the past that have been relatively successful. But this was initiated in the early days of biodefense. There hadn't been any approved drugs for pneumonic plague, and the plague approvals, the last one had been done about 50 years ago and was done entirely on in vitro data. And so we took it on to develop an animal model, working with J&J, with levofloxacin at the time. It was under patent. I have to give them credit because during the development of this process, their drug went off patent, and yet they continued to work with us on that. But this was a collaborative effort of NIAID and the FDA. They were involved in the animal model development as well. We did the studies. The Department of Defense facilities actually conducted the studies, and working with Janssen. Levofloxacin was actually the first antibiotic that was approved under the animal rule by the FDA. We also submitted data on ciprofloxacin. This is an old slide because the FDA has subsequently ruled on Cipro. And the reason why that took so long involves understanding the nuances of how the FDA regulates generics, and it's a story meant for a couple of years because it's really bizarre. The development of a safer smallpox vaccine, which we'll probably hear a little bit more about, was one that involved a wide array of companies stepping up to carry this forward and then putting in their own resources, but at the same time, our animal model development and assay development assisting, as well as adding clinical trial support that really went into a lot of our funded efforts with the company to move it forward, and then transferring onto BioShield and entry into the national stockpile. This is an interesting story in terms of diagnostics because this was one of our early funded efforts trying to move the field of multiplex diagnostics forward, which we think has a tremendous amount of advantage. Obviously we had generated a wide wealth of genomic data on all these sequences. The company came forward with a multiplex platform technology that then we were able to fund them through a series of 2 of those partnership awards that I described, along with a small business grant, to really do the engineering to develop this into a system. Now this is interesting because one of the issues with multiplex is this actually tests, this is FDA cleared now, it will test for 20 different respiratory pathogens. At the time the FDA first issued the clearance, they only received clearance for 14 of the 20. 6 of those were subsequently masked because it was insufficient data. They accumulated additional data, and after about a year and a half, and were able to get 5 of the remaining 6 approved as well. The final one deemed that there would be insufficient clinical specimens ever obtained, and So at that point, the FDA actually allowed them to submit spiked data, spiked samples in lieu of actually having actual clinical specimens. And this, I think, is very critical because with an emerging infectious disease, particularly a brand new one, we may not have enough clinical specimens in order to get a diagnostic moved forward in order to address that response. So the ability to actually submit spiked data, spiked samples in lieu of clinical specimens is really important. And the results of this subsequently led to a collaboration we had with the FDA to actually develop specific methodology around how we go about spiking samples. And the first publication in that work was just released, appeared last month. So it's a very good effort in terms of moving the field forward, of making it possible for low-frequency pathogens to actually be developed. So I mentioned transition partners. BARDA is one. We have all sorts of transition partners that we think of. We submit data packages directly to the FDA, as I showed for the J&J and Cipro data. We've done studies for CDC to support clinical guidelines for the use of some of the biodefense applications that we have. We've done specific studies with regard to HHS to define utilization policies for how we might act in specific situations. We've transitioned products to DoD who have specific warfighter requirements. But NGOs, biotechs, and big pharma, obviously public health attributes beyond biodefense and other commercial applications, we certainly look for that. So why are partnerships useful to us? Well, I think there's a couple of things that in general partnerships are useful broadly, and that is when there's insufficient commercial attractiveness for private investment, nothing's going to get done. We can carry it so far, but we need a partner to really carry it forward. There's a lot of the potential for uncertainty really holding back development, I think, is a key issue that we have to address. And there may be uncertainty about the scientific foundation for what we're moving forward. One could certainly make a legitimate argument about Zika right now that we just simply don't know enough to really have a company consider investing a lot of resources into it. As I mentioned, for new innovation in terms of innovative interventions, there may be quite a bit of regulatory uncertainty of just not sure how this is going to be approached and what we should do about it. And in many instances, there are manufacturing complexity versus the cost. May say, we know we can do this, but we're not sure we can make it cost effective to actually make it a viable product. And that may hold back work going on. I think one of the issues, and again, it's for a lot of other people to discuss, is unresolved issues around distribution. This is particularly a problem in something like a public health outbreak or a biodefense event, where the company is going to sell to somebody, and then in the midst of an outbreak or a bioterror situation, somebody else is going to be using that product. So the company really doesn't have a handle on how it would in fact be used. And then the last point we've seen where partnerships are very helpful is that in some instances there's complex development requiring multiple intellectual property entities being brought together. This is very common in the TB field, where we assume combination drug therapy will have to be used. And so you may actually have two different companies whose drugs need to be put together. It's very hard for, in many instances, for those two companies to work together because of several issues, and creating a partnership with which to do that is very easy. So obviously these are some of the reasons why we, in terms of what NIAID brings to the table, can look pretty good. So when there's insufficient commercial attractiveness, as Joe mentioned quite eloquently about anticipated future revenue streams, the partnership approach allows us to fund that early phase development cost that goes a long way to lowering risk reduction, because we know that a lot of the attrition, a lot of the failure is in the early stage. So I'm willing to pay for those early stages or early stage failures because my success is really predicated by shots on goal. So I've got to support a wide array. I'm juggling a lot of different projects, knowing that I'm going to drop most of them. They're just not going to be successful. But for any individual company making that decision, it's really tough to do on their own. Now, for uncertainty, I think, from a scientific foundation working with NIAID, we have a lot of scientific expertise to leverage, particularly when you're trying to get the adequate concept vetting along with proof of principle to justify further investment. So if you think you have something very early stage, not sure whether it really has good solid data and evidence behind it, we have the capabilities to really bring to bear a wide array of scientific expertise to design that specific animal model or that specific in vitro test that can really provide the definitive proof of what you need in order to feel comfortable moving forward. As I mentioned, with the regulatory uncertainty, we have the ability to work through with a product-sponsored, independent manner with the FDA to really try to address some of the critical issues that create that regulatory comfort zone for the FDA to feel more comfortable. And manufacturing complexity versus cost. We have multiple examples in our partnership program of where a major effort there was to really demonstrate the manufacturability at a larger scale. We see many examples of where a bench-level scientist can make something work, and the concept is fully vetted, and no doubt if you can manufacture this product, it's going to work. Unfortunately, when you try to scale it up, you just simply cannot do it, or it's very expensive, or maybe have some technical issues that really need to be resolved. Solving that through one of these partnerships is quite successful, allowing us to move some products forward. Now, the unresolved issues around distribution, I think this is something that is not always given a lot of attention. What most people don't appreciate is pharmaceutical development works backwards. You begin not at an idea that you think can lead to a product. You think of what it is, what is the unmet medical need, and how would that unmet medical need be met? And you work backwards in terms of putting together a development plan that will get you to that final stage. With a lot of emerging infections, public health outbreaks, biodefense type related issues, it is very unclear what that end stage looks like. Who are we really going after? Who do we really want? Zika is a good example of this because the first thing everyone thinks of is pregnant women, but as was mentioned earlier, pregnant women are probably the most dangerous things to think about treating. I mean, you're talking about a vulnerable population. That's it. Those are usually some of the last people we get to because we're so worried about establishing safety early on. So if you tell the pharmaceutical community that we want a drug to treat pregnant women to prevent birth defects, I think everyone is just going to quietly turn around and walk out the door. So there needs to be some thought given, and it's not always something that the private sector can do very well. So in terms of how we can go about defining what that end user looks like, how is that end user going to get it, how is it going to be delivered, those are key issues that can be addressed from the public side because really the public sector is demanding that we need something like this, and we need to put that time in to really define what it is. And once you do that, that really constrains or refines the types of countermeasures you're really interested in. Now, the complex development, legal and liability concerns, again, some of this was mentioned earlier, and I use tuberculosis as a good example. We've seen instances when large companies will have an antibiotic development program, and the compound itself may fail for the indications that we're going after, calf, skin, and soft tissue, or something like that. But it does have in vitro activity against TB. Now, the company is not really configured to move that forward for TB because it's not going to be a TB standalone drug. They would have to find somebody else to partner with. That's a difficult proposition. But there are other partnerships and alliances that are geared towards doing this. But an entry point for them is that TB therapy is usually protracted, 6 months. So you may have acute toxicity data on that compound, but you don't have chronic toxicity data on that compound. So one of the things we've done is actually provide chronic toxicity testing for TB candidates so that a company can get that assurance, and then they can then work in partnership with an alliance that would partner with other providers of potential candidates so that the partnership can then move forward. For those types of things, particularly where combination therapy is likely to be the case, that's a very ideal situation. Others we've seen where this can happen is when you have combination vaccines where you may have a particular type of manufacturing platform, you may have a particular type of adjuvant, and you may have someone with the antigen. We can come together in a partnership arrangement organized through one of our funded programs to make that work. So I think, in summary, public-private partnerships are clearly for public health types of issues that the private sector on their own is simply not going to attend to. The public side really has to bring certain features to the table, including prioritization, the insight of the end user. I think that's really key. And as Joe mentioned, and I'll the ability of having unique technical and regulatory expertise, I think, is a key component of what we can add. And the other issue that I would say from NIAID's perspective is familiarity with all the relevant potential participants. And so we may only be carrying something through phase 1, but we know who all the likely candidates are that other partners that you may get involved with down the road. We did this quite nicely for Ebola. We'll probably end up doing this with Zika, when we actually have a product that we can think about moving forward. The private sector, one of the key things we really want to see is novel technologies, and I think that's one of the ability to actually break in to sort of get that non-dilutive funding to vet your novel technologies, I think is the key thing that we're really looking for, and that's what we hope people come to us with. And the willingness to engage in a team sport is really critical, because the only way these things get done is with a large group. So I'll stop there and take any questions.
Quick questions.
So in the aspect about novel technology, the only avenue the investigator has is, let's say, Punch 21, which are highly competitive, funding rates are very low, you sort of live at the fate of the primary reviewer. Are there other mechanisms that go at the sort of principle of what the R21 was intended to do and actually does get a
So there's another one, the RO3, which is kind of similar, but maybe not the same. I think requires less preliminary data. It's more for an idea kind of generation. The partnership award, the partnership program is really geared, and we sort of adjust it from year to year. So sometimes it'll be very, very early stage in that translational space, where you're really trying to refine and vet the concepts of that novel technology, or demonstrate the potential for that novel technology. In other cases, we have a little bit more further along, where you're really trying to adapt it to a specific clinical indication that you're going after to use it. But for example, one partnership award that was very successful was the development of just an adjuvant. It was not tied to a particular vaccine. It was really around the crucial issue of developing, demonstrating the manufacturability of that. And through that partnership, that adjuvant moved successfully in development, so that it ended up being licensed to about 7 different vaccine companies. Now, the success of that is a whole separate issue, but getting that particular candidate forward enough so that it can actually be used in all of those other projects was a key point of what we were trying to achieve.
One more.
So Mike, thanks a lot. One of the projects that we fund is, as I mentioned, the T Drug Accelerator, and NIAID is a member of that. So that's one of those projects that involves bringing those compounds out of libraries from the pharmaceutical company and into development, ultimately into the market. And in that context, we, as the foundation, we obviously are very concerned about, as I described, global access for our target populations. But can you just talk very briefly, just almost philosophically, about the quid pro quo that you expect with your investments, where all these different actors are involved in terms of access conditions, in respect to developed products once they're brought to market?
Well, quid pro quo. That's a yeah. So I think we are answerable to Congress, which is the ones who give us the money, and they've clearly indicated that they'd like to see more tangible benefits according to society from the investments that we make. And so the issue is when we see a lot of very good science left on the table, you see a lot of stuff come out. Most people who are scientifically trained can read the literature, and you can see things that have potential. And then years later, nothing happens with them. And the question is, why is nothing happening? And in most instances, it's either because the right experiments were never suggested to figure out if they could move forward. In other instances, attempts were made and it just didn't work. And so the issue here is as Joe pointed out, related to the accelerator, is that a lot of companies we work with fail completely independent of technical, scientific, or medical reasons. They fail because the company just wasn't configured properly. The company just couldn't put it together. Now, I have no control over that. And one of the rationales for the accelerator is precisely to try to address that component. But from my end, if something fails, I want it to fail because it's been adequately vetted from a technical, scientific, or medical rationale that it should fail. And I think in many instances, although journals hate it, I think negative data is probably equally as valuable as positive results. Only insofar as I can tell you, during the Ebola outbreak, the number of inquiries we received, we think you should try this. Well, that was tried a long time ago, it didn't work, but we couldn't get that published, or it's buried in the table somewhere, or something else that gets published. So it's really trying to improve the shots on goal, because I'm not really convinced that we can improve I don't think we can improve our success rate. I think if it were possible to improve our success rate, the pharmaceutical industry would have figured it out a long time ago. So I think this is the level of biology we're stuck with, and so our what we're looking for is an adequate vetting of as much as we can take advantage of that's being produced by the scientific community to really explore the potential applications to improve public health. And that's really, in the end, what the game is all about.
Quick question, as you can notice we're behind. Should we go ahead and let David Noble speak and then have a very quick break after that, or do you want me to break over? Break, somebody go. Break. Okay, 10-minute break. 10-minute break, and come back and we'll
There's
just do the best
some
we can.
sugary treats on the front table.
Lots of sugary treats. Sugary, whole table of sugary treats. Yeah, I have to stay away from the end.
Yeah, it's a good idea.
Nice to meet you. My name's Howard. Hey, Howard. I'm an undergraduate here too. Are you Mr. Watson? Yes, I am. So you must be Harry. Yes, Howard. Yeah, Howard. Today my group and I presented one of the projects of the Zika Challenge downstairs during lunch. Yeah, I missed that. I was up here. We were really interested in this event mainly because we wanted to get some expert opinions and some a little bit more knowledge. And we were interested in the gamification specifically. We wanted to learn a little bit more about what kind of initiatives you guys fund. Because I know that the event today seems more focused on the science side and a lot of the bureaucratic and political issues. We were also wondering addressing how to track Zika. And specifically, we thought it'd be a good idea to use the digital system as the focal point for tracking it, because it's such a attracting event for people all over the world, especially if people have having problems. It's quite a Zika right now.
It's been a lot of things. Well, no, not at all.
Using existing platforms, especially social media platforms, already have a large user base for Zika travelers get to Rio, they're almost surely going to be social media sites saying, hi, I'm here in Rio. And through these social media platforms, I'm hoping that we can send out a survey or use it as information kind of about the virus itself and gathering information from the survey about like speed of bites or like symptoms that might be showing which would tell us whether or not that's eco-friendly. So in the next few steps of our project, we want to look a little bit more about like funding and logistical issues, and that a lot of our ideas build on what already exists, so it's not so much that we need to create something so much as we need to get connections and have social media sites actually start implementing such location tracking.
That's a great idea. So,
Okay, I got you. All right. But yeah, so I gotta get my should have called.
that's it. Surveillance.
Oh, okay. Okay. Anyone?
In that context, also interesting what you're describing. Sources of information. The spread of just disease. But the idea of my day is just the person, which is predict dog. Yeah, just
Are you ever part of the bidding process? Or is it just like different committees and stuff? I'm with research. Kevin? So we've been doing, full research, and then of course it kind of took a competition class. You would pull out the foundation. It's a little bit of, collaborative effort there. It's not to purchase those and those on the website. Yes. Did you see the video? Okay. She's really big. I like her. She's it's been neat working with them, because I just got on with her in January. I graduated from school of nursing and so graduated here in December and less than a month later I'm at Sierra Leone standing up the plasma studies with so once again another year because that was all trust money. So You know, I'm curious if you brought in any initiatives because Papa Salif, he actually had to get into a couple telephone calls and stuff. Because I don't know if that name's out there yet. Because I know you guys got a couple. And then
one day here, and then they're very coordinated, so the community, and oftentimes two students doing the same thing right next to one another, and they don't have to talk, they don't plan, they don't just work together. There are oftentimes been
Boy, that one, I don't know. Just, just like talking about all
this
this.
area of Haiti, looking at they don't have transportation. They might have no beds. Most of them are walking many miles with their children to go to whatever area it is that they can seek help. And sometimes they're being turned away and told, no, you actually, your baby is 1 pound or 2 pounds in a different category, so you need to go 5 minutes down the road by car, but could be like 5 minutes down the road to
Just, right on the ground. That was just
Oh, yeah, Dave should have been. Yes, Bonanza.
you make the game much more successful, whatever it is. I can imagine. Yeah, there's not much left. They can't study.
Oh, good. You have to do something. Never did those two.
Whether you like belch or not, I'll talk about that.
I've never met Peter Dahl, but the first time I just kind of walking by, I think someone talking about it. It's like, Ryan called me the other day.
It's all out.
I think until you do something that you might not know maybe.
I guess that was kind of that was the bane of my existence, sincerely.
That would be
Like,
very
he even took pictures of me while I was in Liberia. It's like,
yeah.
kind of had his ways of having his minions and stuff. Just like when Joe first visited Sierra Leone, there was actually somebody waiting for him. Yes, I am. I'm looking forward to meeting Brian here in a couple of things. And it just kind of kept going. But it's just, for some of us, it's like crazy things like that.
It's about time to wrap these down. We have 2 Davids on the sequence now.
You're welcome to job
Okay, I'm going to introduce David Knoll, who's Director of Scientific Affairs at Bavarian Nordic, and by the way, another one of the sponsors of the meeting, so please thank him for all the efforts he's done too. Before David joined Bavarian Nordic, he was Senior Public Health Analyst for the U.S. Department of Health and Human Services. He assisted in establishing the National Biodefense Science Board mandated by the pandemic and all hazards and preparedness Act of 2006. He was a congressional fellow to the Senate Committee on Health, Education, Labor, and Pensions, where he provided expertise to committee staff on issues requiring an understanding of complex scientific and regulatory matters. And I tell you, he gives a mean-hour talk on understanding government funding of pharmaceutical development. I took notes copious. So, Dave.
Thank you. And we're happy to support this effort and efforts like this. As companies, as academia, as the non-governmental organization, we'll think about how to incentivize and get companies to come and play in the space. Bavarian Nordic has cut our teeth doing this, so I have a lot of experience. And part of my role, and I'll talk about this, is really to think about how we can continue this effort going forward, or participating in this effort going forward, because as a commercial company, we've got to be able to make money doing it. So we're not GSK and we're not Merck, so I'm just going to do a little bit of introduction about who we are. There we go. So we're a medium-sized biotech company. We're actually based in Denmark. Our corporate headquarters and manufacturing facilities in Denmark. We have a large research and development facility in Munich, where most of our infectious disease work is done. And then we have a immunotherapeutics, cancer immunotherapeutics group that is based in California. So our core competency, all of the products that we work on, all of the development programs that we work on, are all based around our core competency, which is in pox viruses. So modified vaccinia, fowl vaccinia, any of the pox viruses can be used in a variety of different either therapeutic or prophylactic indications. Is the area that we work in. So our two main programs are in cancer, where we actually in-licensed from the NCI pox-based prostate-specific antigen immunotherapeutic. That's in phase 3, currently fully enrolled, and we're just in the process of monitoring events in that trial. It's a broadly applicable technology. We have development programs for bladder, colorectal, breast, all based on the same poxvirus platform. And then in the infectious disease side, Immune is our smallpox vaccine. And smallpox vaccine, our entire program on Immune has been in partnership with the U.S. government. So our first interactions with NIH were 2001, 2002. Our first contract was with NIAID. Our second contract, that was in 2003. Our second contract with NIAID was to explore commercialization of the manufacturing process. That in turn led to a procurement contract with BARDA. Project BioShield procurement contract that was to deliver 28 million doses of Immune to the Strategic National Stockpile. So we have partnered, and we've done the product development from basic research with NIAID all the way through delivering product to the Strategic National Stockpile. It is in the wonderful world of approvals. It's actually approved in Europe and is not approved in the United States, so it is stockpiled in the U.S. under an emergency use authorization. But the definitive phase 3 studies that are required for licensure in the U.S. Are ongoing. It is MVA, so it's a modified vaccinia oncoral, which is our platform technology, and the reason why I'm here talking today because we use it as a platform for lots of different things. We have we have a multivalent filovirus vaccine component that was partnered with Janssen, and is part of their AD MVA heterologous prime boost development program. And when we looked at the lessons learned from those, so everyone's seen some version of these different points at one time or another. The key one, the first and second ones are really the ones that I think are important. If any one of the viral vector products, so whether it's GSK's chimpanzee adeno or Merck's VSV product, Johnson & Johnson's ad or Bavarian Nordic's MVA, if any one of those had actually gone through a phase 1 study and there were sufficient doses available, it would probably have had a material impact on the outbreak of the disease. As it was, all of these products were just basically a couple months shy of being really able to be rolled out in a way. And, presumably would have been rolled out and used in high-risk populations, so medical professionals. And the data that's coming out from the VSD trial, as well as the comparative work that's being done with the other programs, is that they probably would have offered some level of benefit, significant benefit in many cases, to those healthcare workers. And so this is, the quote from the WHO. It was really a collective failure. We need to figure out how to do things better, do this process better. So we've been thinking about it. GSK clearly has been thinking about it with their BPO. Merck has been thinking about it. BARDA's been thinking about it. We've been thinking about it. So WHO has a call for proposals out, and with sort of a set of potential criteria. And we've been thinking about it. We've been trying to figure out how do we address this set in a way that's actually sustainable from a company standpoint, a mid-sized company like ours. So they want flexible development platforms. They want to be able to see phase 1 data before an epidemic, and the ability to rapidly scale up in the event of that epidemic. And they want sort of demonstrated ability to produce at scale. So that's a challenging part. And then some of the top priority threats. So as we thought about it, at Bavarian Nordic, sort of broken down the process into these different areas. Point at which the threat is low, sort of know about it, we should be preparing for it, but money becomes the object. So that would be Nipah, Lassa, Crimean Congo, hemorrhagic fever, all of these for which, there's certainly not an epidemic, but there could be. Ebola was in this case for the entire time before 2014, and then rapidly moved from moderate to crisis. And MERS is probably in the moderate phase. That's how we should be addressing this. We should be really thinking about it. And Zika now, in the course of just a couple of months, went from low into sort of crisis. But it's too late. Once you get to the moderate, the crisis part, it's too late to be really doing vaccine development. The early work has to be done, in a low threat environment. We have time, we have adequate ability to develop the animal models Mike Corella mentioned earlier. We could develop an MVA-based Zika vaccine, have GMP material available within a year. Very little understanding of the actual disease pathology, of the disease itself, spread, whether that vaccine would be effective. You need time in order to do these things well. So we really focused on trying to design a platform proposal that uses the MVA platform to address this earlier stage, this low threat stage, recognizing then that you need to be able to do the second third, the modern crisis production and testing capabilities. And I'll just run through our experience with Ebola on that, where we did rapidly scale up to commercial scale manufacturing. But I do think it's important that at the end of whatever development, whether it's the end of phase 2, the end of phase 1, you want to have on hand a significant enough of a stockpile that you could move immediately into phase 2 and phase 3 studies. So more than typically generate a GMP lot, so more than 2,000 doses, but less than 200,000 doses. Enough that you really can make. And you want in that pre-operating manufacturing phase to really demonstrate that if you need to scale up, if you need to be producing millions of doses, that you can already do that. And you don't have any development work that you need to go into that. So our company uses poxviruses, and MVA is the one we primarily use in our infectious disease space. So it's a viral vector, just like GSK's chimpanzee adeno or the VSD, with a couple of exceptions. MVA is much larger genetically, so you can cram a lot of material into them. So typical viral vectors you usually are able to put in, say, the glycoprotein of Ebola, or Ebola Zaire. So if you want to have a product that's protective against Ebola Zaire and Ebola Sudan, you have to have 2 different viruses. MVA, we can cram a lot of material into there. So multiple insertion sites, different promoters, all the sorts of biological techniques and tools that you need. MVA is nice in that generates both B and T cell responses, and this capacity to include lots of genetic information allows you to develop things that are multi-valent. MVA is also being used by everyone to study everything. It has been used in local health programs for malaria, TB, and HIV. Products have been developed in Ebola. There's a MERS candidate that's going to phase 1. All of those are wonderful and speak to the capability and capacity of MBA from progenetic information to be potentially useful in a variety of different pathogens. The bottom part, the commercial disease targets, is what makes it a viable platform when you think about epidemic diseases. You need to have a commercial requirement for it so that you can be constantly producing, so you can maintain a manufacturing facility that is always capable of switching over to another product, but that is routinely selling something for which you make a profit, so the company like Bavarian Nordic can stay in the space. So we have an RSV vaccine development program. It's moving into phase 2 later this year. Our oncology products, our cancer immunotherapeutic products, are all manufactured in our same multi-purpose facility in Discard. And we've entered into licensing deals with Janssen for a therapeutic HPV vaccine, all underpinning sort of a commercial capacity to maintain the infrastructure necessary to be able to respond to an emergency. Just a couple of, this is from another source. I don't have it. So there are lots of different vaccine platforms. The advantage of MBA, in addition to being able to do lots of things with it, large genome is these three, which are specific to MD-ABN, which is a very large proprietary strain. It's been licensed in Europe. FDA has a tremendous amount of experience with it. We deliver 28 million doses. So the regulatory challenges associated with using our platform are much less. We've been inspected by Health Canada, EMA, FDA, all inspected manufacturing facilities are all comfortable with the production process, understand where the potential sources of contamination are, and we have control for it. So those are things that can reduce the challenges associated with deploying a vaccine platform. We've delivered 28 million doses. We've been manufacturing continuously at the facility since 2010. We'll produce 4 million doses of Imvamune this year, as well as several campaigns manufacturing our immunotherapeutics product. And then, I'm sorry, it's the last one. And then BARDA, in addition to funding the procurement of Imvamune, has also been funding the development of freeze-dried lyophilized formulation of the product. We anticipate that this should be applicable to all our other recombinant products, and part of our work under a subcontract with BARDA was an option to develop a multivalent filovirus vaccine candidate as a freeze-dried formulation. So all of these investments that have been made by the U.S. government are, in many cases, directly leverageable by any subsequent development programs that might come about. So it's a platform, like many platforms, it's a potentially applicable platform. The one thing that we actually had the wonderful, not so wonderful, the unique opportunity to do was actually exercise this large-scale manufacturing capacity. And we did this during the Ebola crisis. So just a quick overview. So if you look at the top, the 4 different stages of vaccine development, design, and generation, the sort of preclinical testing, clinical material production, clinical testing, commercial scale manufacturing, nicely sequenced out. We had developed MVA-AVN philo, so it contains the glycoproteins from Marburg, Zaire, in Sudan, as well as the nuclear protein. That work was done under contract with GHIA, beginning in 2011. And we've been going through pre-crisis a number of different iterations on the design, use of promoters, other co-expression molecules to see if we can ramp up the immunogenicity of it. But very much sort of in the design, iterative process of figuring out what the optimal product would look like. In mid-2014, NIH, because they can do this, combined our product with Janssen's adeno product in a heterologous prime boost. So this is just data showing you boost first with Janssen's Ad26, Ebola Zaire, followed by MVA-BN, or vice versa, beginning with MVA-BN. And then at the Ad26, you get complete survival. And in the midst of this growing emerging crisis, this data was quite compelling. Note, the BN program and Janssen programs were entirely separate. Those were not a co-development program at that point. But once this data came about, and a sustained commitment by Janssen to really make this product development pathway feasible. So Janssen approached Bavarian Nordic in late October about a supply agreement where Bavarian Nordic would produce the multivalent philo and provide it to Janssen, and then they would be responsible for developing the vaccine. It took a couple of weeks to negotiate that deal, and we then began manufacturing within 5 weeks of that. We had never produced at commercial scale. We had a couple hundred doses of clinical grade material available, and we had a small amount of viral stock. We took it right into our facility using the exact production process that we use for Immune, no process development. And within the first 5 weeks, we had produced 500,000 doses at commercial scale of bulk. It used the same process, it used the same existing raw material supplies, trained personnel, facility. We were able to just literally shut down our immune production, which we were doing for the US government, swap in MDA and philo, produce, then we had a Christmas shutdown, brought the plant back up, and continued manufacturing the philo. And we produced 2 million doses, bulk in 9 months. All of that material since then has been filled in 12 months, complete product release of 2 million doses. So at scale, and this, when you go back and you talk to our manufacturing folks, they were crazy. This was the development that, when you told them, yes, you're going right into commercial, into our large-scale manufacturing process with a seed stock that had never been used in anything but a much smaller scale product. They were, they knew they could do it, but they were sort of incredulous that the process would move that quickly. But having in place the facility and all of the necessary requirements, raw material supplies, training, allowed us to do that. And we can essentially do that for any product that's directly based on MDA. So we sort of demonstrated that the platform is applicable, and the large-scale manufacturing is possible, but the whole system was entirely suboptimal. You don't want to be doing things in an emergency. It's too late at that point. You want to be able to think about how do you set up a system like this that works in advance before there's an emergency. And I will say, I'm talking about MDA, but there's nothing unique about this. Every viral vector, there are a variety of different other platform technologies for vaccines that could apply the same thing. And we would advocate that the funding agencies that think about which platforms to pick, they should probably pick all of them, because some aren't going to work. They're going to work in combination. So our MDA worked. We've used our MDA and we boosted GSK's chimpanzee adeno. Janssen's product would never work with Merck, but there's no reason why you wouldn't see necessarily a bump up in the benefit. So these mix and matches, so far to the old days in the pandemic influenza, just sort of mix and match looking at products and adjuvants. The same sort of thing should be considered when you think about developing vaccines, especially the viral vector vaccine, which are going to have similar inserts, similar targets, and additive benefits. So when we thought about how do you put something together that fulfills this early phase, the pre-emergency response. And so we came up with this idea and have been actually actively going out and identifying potential collaborators in the academic setting and in the sort of government research lab setting that can fulfill that. So we really thought about everything that can be done up into including phase 1. We put the cutoff before going into phase 2, but specific to the product, we usually understand what the dosage is going to be. We wouldn't have to do really dose finding studies with MDA. But that whole section in green, so design, preclinical evaluation, optimization, GMP manufacturing, IND enabling studies, clinical studies, and then the necessary process developments to support commercial scale manufacturing, and then a couple of large scale models. So you generate a mixed stockpile of finished, filled final drug product and bulk drug substance. You stick it all in the freezer, and you hope you never need to use it. But more than likely, because at that point you don't have, for Nipah or Crimean hemorrhagic fever, you're not going to do a clinical study unless there's a need for it. And so the cost of taking the product fully through development is simply no longer, for a lot of these things, worth the investment by the payer, who's going to be some public source, whether it's a government, an NGO, or a consortium. And the Bavarian Nordic is really focused on, we can't do basic research. You know, we could, but that would be diverting our clinical team and our preclinical team from RSD and our immunology products. We can't do that. We were able to do it within the immune because we noted that there was going to be a significant enough payoff. The US government committed to buying up to 20 million doses, and we knew there was a sustainable business model there, and there isn't a sustainable business model for these products to take them all the way through licensure. So we look at how do you cut it off, where do you cut it off, and how do you get, and how do you make it sustainable for a company like VNA. So our first iteration is before WHO put out their priority pathogen list was we would just take everything. You know, we would partner with anyone that has either disease expertise, and has since narrowed it down and really looks for labs. Because MBA has been used in a variety of different programs by a variety of different researchers throughout the world, we really gone through and selected and identified folks that have candidate vaccines in MBA. And what we're doing is we're making available to them the MBA platform so that in subsequent development for new products or new products that they already have, that we can put them in MBA again and leverage them, all the investments the US government has made. But this is going to be an iterative process. It's not the sort of thing you can do in an emergency scale. This is all sort of pre-emergency, iterative vaccine optimization. What are the antigens that you need to improve? It need to be structural. Does it only need to be structural? We need a T-cell component activity. And then there's going to be efficacy testing. This is an iterative process. I'm not running over, am I? And then you move into the more expensive parts, phase 1 evaluation and production. With the goal being, at the end of a 10-year process, you've got 200,000 doses, 5 different vaccines that have been through clinical testing, and in the event of an emergency, could be used under a phase 2 study. So very much getting to just beyond the point we were with the Ebola vaccines, so that it could be useful in an outbreak. So very specifically, so this is a breakdown of the different activities. So in preclinical, this would not be necessarily Bavarian Nordic's responsibility. We would be partnering with different agencies, different organizations throughout, primarily Europe at this point, but we're also looking and considering folks in the US. Antigen identification, vaccine design, non-GMP production would be done either, the production would either be done at Bavarian Nordic or could be done in these research labs. We would all utilize MBA and preclinical evaluation, including immunogenicity and efficacy, with an eye towards demonstrating that the products are likely to be beneficial. So one of the problems with the Ebola development programs were we had all these products. They all were at the point at which you could have taken them into phase 1. And if it had been, for RSV, companies would have moved every one of those products into phase 1 to begin getting those data. There was sufficient preclinical data to warrant transition into the clinic. There was a great deal of risk aversion because it begins to get expensive. It's right with the 7 candidates that were out there. I think we need to be a little less cautious about taking the phase 1 studies because without having that initial phase 1 data showing that it is actually safe, you don't get a large safety database, but that there's an immunogenicity, a measurable immunogenicity that's correlated to what you have seen in animals, not correlation for approval, you're not going to get that, but it's sufficient confidence that the product could actually be beneficial. Then you move into the clinical trial, much less risk averse than you've been in the past. Produce the clinical trial material, do the phase 1 study, and if it warrants, if you get the readout that you think is sufficient and appropriate, you do large-scale manufacturing. And with our product, large-scale manufacturing is relatively straightforward. You need to reserve slots in our facility. We've got all the material coming in. To do that, as long as you've got enough time to plan it, it's not a disruption to our business. Do that. Produce a couple 100,000 doses, goes in the freezer. We've identified out of the WHO priority pathogen list 6 that are, well, 5 that are very well characterized for compatible with MBA. Zika, based on work that we've done with a test version of a yellow fever MBA-based vaccine, we think Zika is a candidate for it as well. What we've identified in the first column, those are all ones for which there are active programs already ongoing with our partners. So MERS and Crimean Congo hemorrhagic fever, both European-based research institutes, and then we're contributing our own multi-level program to it. We've also identified performers that have the biosafety ESL4 containment facilities necessary to do all the studies, so that this is an issue that Mike Earl raised. Again, we're not going to be doing that. We're going to be doing the downstream, the production work. We've even partnered on the clinical trial, notionally partnered on the clinical trial work, so that we would be doing that. We'd be really focusing on the manufacturing component of the program, but doing it for a number of disease targets. And this is where it becomes. So we had a GHIA contract for multi-valent phyllo, and we had that since 2011. And that product, as we go in, it had a phase 1 study in it, had GMP manufacturing, but product had kept changing, it wasn't ready. Including a number of different targets, a number of different candidates allows you to do a portfolio type approach. So that if one isn't ready, then you can move to another. This is the key to sort of coming up with a sustainable model that allows a company like Bavarian Nordic to do it. We know in 2 years we're going to need to have a production slot, and in year 3 we're going to be producing clinical trial material for another. Could be Zika if we're racing along. Could be MERS. We have the ability to plan in advance that a candidate will be coming through. So long-term, sustained, regular. That's what has made our collaboration with the U.S. government useful. This is very hard to read. The top is all of our contracts with the U.S. government for immune, for the development of the immune platform. The orange in the lower left-hand corner are freeze-dried vaccine contracts that have been awarded. And then we've received funding from the U.S. government for a variety of different applications of the platform for different diseases. We've done work with BARDA, NIH, Department of Homeland Security, Department of Defense, and the ability to secure regular committed funding and know long-term that you've got a partner in there has been essential to making DN willing and able to do this. Just that again. So when we plan out what it looks like, it's the periodicity of this, it's the very boring nature of this that makes it a potentially commercially viable product. You've got a number of things going on in preclinical. We've got the first couple lined up, assuming that everything moves like we think it would, and then the production runs would be spaced out over a regular period of time so that we can do all the planning necessary to do that. We estimate $20 million in target to get it to phase 1, through phase 1. That will vary somewhat. The preclinical costs in preclinical work will vary. Clinical testing, $6 million for phase 1, including the GMP manufacturing, and it's $8 million for the production runs. So about $20 million. If you put this over 10 years, and you end up with 5 products at the end of it, $100 million investment spanned over 10 years is for Bavarian Nordic, who only gets a portion of this, only gets the manufacturing portion of that. But again, regular, sustainable, predictable funding is, in many ways, more valuable than getting a phyllo contract, Crimean contract, hemorrhagic fever contract, and a Zika contract. Never being sure which one of those is going to proceed along. I'm not discounting the value of additional incentives. The $20 million number per target, that's a push incentive. That's fee for service. Government, NGO, whether it's the IMI, the UK is now a big initiative. Whatever that is, that's just covering the costs of those projects. Additional whole incentives would be, of course, welcome. There's some, the value of those, from an economic standpoint, what that is and how much those are can be calculated into a net present value are important. And unless the base costs are covered, almost no company I think is going to be able to bring in and take on the necessary development without some level of supportive push. So I think partnerships can be crafted that address this is just on the vaccine development part. This isn't how you roll it out in the middle of an emerging crisis, what you do in terms of creative clinical trial design. That's all outside the context of this. As I think you've heard, unless there's a commercial partner involved in this, production capabilities really have to be housed in a commercial partner. I think the MBA platform is one of many appropriate technologies. And this last one, if there isn't sustainable funding, this partnership will remain entirely virtual. The Bavarian Nordic can't undertake this and subsidize this without there being a viable funding partner. So with that, I'll take questions.
Couple quick questions? No, you answered everything. You need $20 million.
How can you then put the fifth Ebola virus inside the NDA?
The fifth one, which
Yeah, there's 5 different types.
yes, so it goes.
We have 4.
Well, we only need 3, so it goes to what the product requirement is. So most of the development work has been funded by the U.S. government. The Department of Defense is the only one with the state requirement for an Ebola vaccine. It's Ebola Zaire, Ebola Sudan, and Marburg. Those are the 3 that are required. So this project began in 2011.
Okay.
It'd be nice, but at some point you have to say, at the time, the only organization out there that was putting out funding was NIH, and with the expectation for the product would transition to a Department of Defense development and acquisition. So that's the funding criteria for the 3.
Because I like that, it covers, yours covers 3, and then of course I want to say it's either the Department of Foods covers, 1 more. But, it would be nice to see a vaccine that covers all.
Yes.
All strains,
All right. So I'm going to reassure you all that since our panel is last, the next day, it's going to be the shortest panel discussion in history. So we're going to ask him right after the next day. So we're just going to make a really short panel discussion. So don't worry, you're not going to be here forever. And David Ridley, I've lost you. So, Professor David Ridley is the Dr. and Mrs. Frank A. Riddick Associate Professor of the Practice of Business and Economics, and he's also the Faculty Director of the Health Sector Management Program at Duke University's Fuqua School of Business. In his research, David examines innovation in pricing, especially in healthcare. He's published articles in a variety of journals, including The Lancet, Nature Reviews, Drug Discovery, and the Journal of Industrial Economics. David was the lead author of a paper proposing the Priority Review Voucher Program to encourage development and drugs and vaccines for neglected diseases. The voucher program became law in the U.S. in 2007, and he's going to provide an update on that program today. Thank you.
So I set my timer for 15 minutes. I know we want to keep things rolling, so I'll do that. And so I'll cut myself off at 15 minutes, but I hope you'll have some questions for me at that time. So I think many of you know the voucher program, so I'll be brief describing what it is. There's typically 2 drugs or 2 vaccines involved. So for example, there's a malaria vaccine. And if you develop a drug or vaccine for malaria and get it approved, you win a voucher. And that voucher is for faster review of a different drug. Let's say a cholesterol drug. And you can sell that voucher. So again, 2 drugs. There's the drug or vaccine for neglected disease, and then there's another drug or vaccine that gets to market faster as your prize. Okay, and so I mentioned earlier in Joe's comments, I really like prizes. This is a prize, and this is a prize resulting in small companies getting venture capital to develop their drugs for neglected diseases. So this is an example of a prize working. You've got a small company that doesn't have the resources, but they're going to get the resources because of the voucher incentive. So there's a doctor here at Duke that's talking to investors now. We hope to have it announced in the next few weeks that is getting venture capital backing. She doesn't have any money, and she works out of what I would call a trailer. Her facility is not impressive, but they're going to be giving her millions of dollars on the potential of a voucher. So here's somebody who doesn't have any money that's going to be able to get money. So I think even beyond the voucher, I just want to talk about the value of prize mechanisms, the value of pull mechanisms. Even if a company doesn't have any money, they can get money if the prize or pull mechanism is big enough. Okay, so let's take a step back about where this came from. So Jeff Moe, Henry Grabowski, and I wrote this paper, and a year later it became law, which was a nice surprise for us. So I'm going to be talking about some of the good things and bad things about the voucher. So we get a lot of the blame for the voucher, but there's plenty of blame to go around. So let me give you some examples of people who might get some blame. The Gates Foundation may get a little bit of blame, just in that this issue of health affairs was sponsored by the Gates Foundation. So the Gates Foundation gave money to health affairs. They did a special issue on global health. They might be more domestically focused usually. I got to present the paper there. A reporter came up to me afterward and said Senator Brownback would like this. So anyway, indirectly, y'all to blame. And you're to blame too, David. So David was working for the Senate Health Committee with Senator Kennedy. This doesn't become law without Senator Kennedy thinking it's okay. David said that what was in part really persuasive is here you have Sam Brownback. You unfortunately probably heard of Sam Brownback. He's been in the news lately. Very conservative Republican. He partnered with Sherrod Brown, a very progressive Democrat, and David said, if Brown and Brownback can get together, it must be okay. So anyway, I think, but all this gives me hope in what's going on in Washington, that Brownback and Brown can get together and do something. Now, we'll see whether you like what they've gotten together and done. Okay, so the law is the paper was published in 2006, the law was 2007. In 2012, it was extended to rare pediatric diseases. In 2014, it was extended to Ebola. Congress wanted to do something about Ebola, and it gave us a mechanism to get some fixes for the voucher. 2015, Food and Drug Administration extended the voucher program to Chagas, and today there's talk of expanding to Zika and expanding to medical countermeasures, and I'll talk about what expansion means for the voucher program in just a moment. So here are the eligible diseases. The original diseases on the list, plus Chagas, plus Ebola, plus rare pediatric. And there have been 9 vouchers awarded so far. The value of the voucher, in large part, comes, Joe said earlier, he talked about a time value of money. You'd rather have $1 today than $1 tomorrow. That's the value of the voucher. You're going to start making money 4 months earlier than you would have otherwise. There are also maybe some competitive benefits. You might be able to leap over a competitor, and you may get a little extra time on the market. If your patent expiration date is the same and you get there earlier, that's more years on the market. Although in some cases your patent expiration will actually move earlier and generics will actually come in earlier, so that's not always the case. I can go through that with you if you're curious about that. It depends on the Hatch-Waxman Act extensions. 4 vouchers have been sold, the first for $68 million, then $125 million, then $245 million, then $350 million. I put this on my webpage. Some analyst then drew the line. I mean, unfortunately, there was a fit to that curve, but some analyst then drew the curve upward and said, what's next, $500 million? Hell no, no way. If anything, it's going to come down. And I'll talk a little bit about why I don't expect it to be 300. I thought $350 million was quite high, and I think that'll come down. So, an example of a drug company or a drug developer, a company moving a drug forward because of the voucher and because they got money from venture capital is this one. So Medicines Development, this non-profit Australian outfit, is bringing a river blindness drug forward in part because they have money from the Global Health Investment Fund. So the Global Health Investment Fund is giving them $10 million. If Medicines Development gets a voucher, they'll sell the profits from that voucher sale with the investors. And so the investors will get a little back. They'll invest in some additional R&D in the future, and they'll use some of the money for access. So they have an access plan, and some of the money will go toward access. Access is one of the concerns of the voucher. Medicines Development and the Global Health Investment Fund, I think, have this figured out. So it creates something of a virtuous cycle where the Global Health Investment Fund is going to make some money on this and then reinvest it in other drugs, devices, and even diagnostics. Okay, so, and we can talk about this some in the Q&A also. I'm moving fast. I've only got 7 minutes. I'm going to wrap up even faster. So flaws and fixes with the voucher. So one flaw of the voucher program is the burden on the FDA. So now FDA has to review a drug, a voucher drug, not the malaria drug or the river blindness drug, but some drug using the voucher, that FDA doesn't think is particularly important, say a cholesterol drug, they have to review that in 6 months instead of 10 months, and that creates a burden on FDA. In anticipation of this, in our paper, we proposed that FDA would get a user fee of an extra, I think we estimate about $3 million. I think that's what it is today. So an extra user fee of $3 million. So FDA is getting a $3 million user fee in general. They're getting another $3 million user fee. They're getting a total $6 million. $6 million to review this drug. Is that a burden for the FDA? The FDA says indeed it is, because they say it's actually hard to use the money to hire people. And I think part of that's about being able to attract talent at prevailing wage, not prevailing wages, at government set wages. And I think part of some reforms going forward are loosening things up to allow FDA to pay more to get more reviewers. Because with $6 million, you should be able to find some people that can review some drugs. Okay, so, Julie, yeah, exactly, yeah, we have volunteers. Okay, and access is another concern. So the voucher is set up to encourage bringing drugs to market, but not ensuring that those get to people. And that's why I asked Dick earlier about what Gates Foundation does for access. So and I asked selfishly, because my question is, what should we do with regard to the voucher? In the original paper back in 2006, we said if you get a voucher, you should give up your patent. That did not become law. I think that's okay. I think we want to keep the initial developer in the game. But in the absence of that, what do we got? And so the best we got right now is there's a proposal from MSF and others, Médecins Sans Frontières and others, which I support, and that is you at least have to write out a plan for what you're going to do. So you've thought through how people are going to get access in advance. You've not just thought about getting the drug to market, but actually how people are going to get that drug. And then if you don't do it, we can publicly shame you. Is there something better? I'm open to it. That's why I was asking. I don't think that's the end of the story. I think we need more discussion of that one. Novelty, concerns about novelty. Good old Martin Shkreli has done us so much good in terms of raising our awareness of some awful things that can happen because of the Martin Shkreli's of the world. So he tried to bring a drug forward that had long been available outside the U.S. for Chagas, but had not been available in the U.S., so would be eligible for a voucher. So part of our efforts right now are closing that loophole. The proposal is that if it's been available for many years outside the U.S., it would not, for that indication, so it's not just the molecule, it's the molecule and that indication, it would not be eligible for a voucher in the U.S. Now the question is how many years? 3 years, 5 years? The trick is you don't want it to be too short because then a drug company will say, well, we're not going to go first into Brazil because we don't want that clock to start ticking. We want to get into the U.S. first. And so, but my sense is 5 years before filing with FDA should be sufficient and should help to close that loophole. And then the last point is about the strength of the incentive. I mentioned there's talk about expanding to Zika. There's talk of expanding to medical countermeasures. I think those make sense because I think both of those are examples of market failure. We just have to be cautious about not getting too many vouchers because vouchers are subject to supply and demand. If you have more and more vouchers, the price is going to fall more and more. And we'll have a paper coming out in Health Affairs next month about the shape of that demand curve, about what that looks like. But just a cautionary tale that each disease on its own probably makes a lot of sense. But if you take it as a whole, so one analogy would be a lifeboat. It's great to get in the lifeboat, but if everybody gets in the lifeboat and it sinks, not so great. So we have to be, so I'm not saying we shouldn't add Zika, I'm not saying we shouldn't add medical countermeasures, but we should just be aware as we expand it, there's a potential for the lifeboat to sink. Okay, so I did that in 11 minutes. And I'm happy to take your questions. Yes, Mike.
Too far into the philosophical, but
we're the university of North.
so essentially, what you're calling a prize is really well. Okay, let me answer it this way. The value of the voucher is basically predicated on either very expensive and or going to be used by a lot of people.
Yes.
So the value, the voucher is indirectly will potentially seek to drive up the cost of medicines, because the desire to have a voucher is, if you don't have a lot of expensive medicines, the drug companies then it really doesn't have any value.
So okay, this is a great point, and I'll repeat it since it's being recorded. So this is a great point, that the value of the voucher comes from making sales of the drug, and making big sales of the drug. And making big sales of the drug represents public spending, and also private spending, but represents spending on drugs. I think this is a fair concern. So what you said that we're in the theoretical space or philosophical space. I'm an economist, so here's a little theory. So economists like to think that markets work. And I realize a lot of people have shown us we're wrong on this, but economists like to think that markets work. And if we think markets work, if there's sales of a drug, that's a good thing because people value the drug and are using the drug. So, and maybe that drug is also creating some competition. Actually, some of the value is actually coming from stealing from another drug. So the sales are coming from the drug you sold for, the cholesterol drug. The FDA says it's not actually that important. The sales are coming from people getting that drug and using that drug and being willing to pay for that drug. And so there's people getting that cholesterol drug sooner, which I think hopefully is a good thing. And it's also there, it's actually coming from stealing from the other cholesterol drug which was on the market. And so that's not necessarily increasing spending, that's just stealing from somebody else. So I'd like to submit that it's not all bad, but this is, or no, in fact it's good. It's good. It's good because people are getting that cholesterol drug sooner and they like that cholesterol drug. But I will certainly admit that part of this is my bias as an economist. Markets, they're wonderful.
I was going to say to that point, I think that probably that criticism would apply more to something like a wild card patent, where you undertake to do research for a drug for a neglected disease, bring it to market, and in exchange for that, you don't get a certificate to give you a head start on the regulatory approval, but you get an additional 1 year of patent protection on any of the drugs. In which case, you really are adding to the cost of that drug to that patient population.
Yes, that's a great point. So I'll just repeat it for the recording. So the problems are much greater with the wild card exclusivity, a wild card with a patent exclusivity voucher or the exclusivity voucher. Anyway, if the reward comes from keeping generics at bay for longer, and indeed so when I presented this paper, a reporter said Senator Brownback would like this. The reason that reporter knew that Senator Brownback would like our papers, he had a bill doing just what you said. And in part, this is what we think is an improvement on that idea. Because what you're describing, I think, is terribly inefficient, because it means people are paying higher prices for longer, and there's some people who would be willing to pay something, but not this branded price, but would be willing to pay the generic price and aren't getting it. That's creating inefficiency. So as an economist, I don't like that at all. So in part, this proposal was a response to that, which I say I don't like it at all. I think it's incredibly inefficient and bad, although the good part of it, the patent voucher, except the good part of it is maybe it does get us some good drugs for neglected diseases or other diseases. But in general, I prefer the voucher.
Can I just ask a question? So I'm still not sure if the voucher program really provides a significant enough incentive for companies to make investments in the development of new drugs or vaccines for neglected diseases. You mentioned, for example, GHIA, and that's obviously a program where there's some push funding that's coming in to fund an activity, and then the voucher is a pull. That list of the 9 priority review vouchers you put up are examples of all 9 are not ones where the voucher was the incentive. That's right. Those were just almost by definition, the law came into force in 2007, so those were all projects that were well underway. Some of them were products that were registered for markets in Europe, and they just simply re-registered here, got a voucher, and bought their own kits.
So this is a great question. So the question is it enough? So if the voucher is, and in fact, in the paper, lots of vouchers, we're going to get lower prices, and will those prices be enough? So is the price sufficient? One thing that helps is orphan drug tax credits. That's going to cut R&D costs in half. But in general, no big company is going to look at this. Let's say the voucher price settles in at $200 million. No big pharma company is going to say, $200 million? That's awesome. We're going to start a research program here. No big pharma is going to do that.
That may not be scientifically successful.
Right. That's right. So now, in the paper, what we said was, it might be enough for some caring person in a big pharma company to say, hey boss, we're not going to lose a lot of money on this, and it'll make us look good, and we can be proud of our company. So, but it's definitely not enough to get big pharma excited, but it might be just enough to satisfy somebody in big pharma. Small companies, this may be a decent prize. And also, the other thing we said in our paper is, if there's something sitting on the shelf, look, we got it through phase 2, and then we said, look, we're just not going to make any money. We're not going to spend the big bucks on phase 3. Now maybe you pull it off the shelf, and maybe you are, and especially if you have some expectations to be successful, now you're willing to go into phase 3. But your question about whether the size of the prize is big enough is a great one. It is not big enough to get big pharma excited, but I think it is big enough to make a difference for some. Yes?
I just want to comment on that because I come from the university transfer office, and this prize is definitely an incentive for entrepreneurs to come to us and look at our portfolio, and it's an incentive for people to look at our technologies that would be early stage otherwise, but now that they have this extra incentive attached,
That's fabulous, thank you. Yeah, so I think for the smaller players, this can be real money. Thank you. Yes?
So Jeff Moe had come to speak to GHIA a little
Yes.
while back, and he had explained that once, I think, pediatric cancer was added to the approved list, that it seemed to almost distract what drugs were using the voucher away from more of the neglected or emergency diseases. Can you expand on that, or if you guys are looking into any alternatives or incentives?
Yeah, so I remember I was outside shoveling snow, which you don't do a lot in Durham, so and Nancy Goodman called me, and Nancy from Kids vs. Cancer wanted to expand it to rare pediatric diseases. She had lost a child to cancer. And I said, I don't want too many vouchers though, because of, and she said, oh, don't worry, there's not a lot of treatments being developed. I think part of it is it's actually hard to figure out who's developing a drug for a rare pediatric disease because you can't search for one name, but anyway, turns out there have been several. And I think part of what makes me nervous is we are getting a lot of these, and if we get a lot of these, we've got a big quantity of vouchers, we've got a big quantity of vouchers, we've got a lower price for vouchers. So I am nervous about that. The rare pediatric eligibility is, I think, very likely to be renewed by Congress, and I think that's okay. But selfishly, as a person with healthy kids, I'm more focused on neglected diseases where there's a huge burden. But I also get it that there's a real fairness argument for helping out those kids. So, but I do think there is a sense in which it's harmful to add diseases because it eventually does make the voucher less valuable, and if the voucher is less valuable, it's even less and less of an incentive. Yes?
Kind of going along that point, is there any considerations for diseases like guinea worm that's really close to eradication, especially because if you're expanding to all these other drugs, it's like there's going to be way less focus on guinea worm, which could be easily eradicated with a few extra resources. So are there any kind of considerations of that?
That's a good question. So, yeah, so the question is, what do we give resources to? Diseases with huge burden or diseases with small burden, but they can be eradicated? The Global Health Investment Fund has given money for river blindness, and their claim is that with a second drug for river blindness, they can get to eradication faster. So the Global Health Investment Fund at least has been willing to give money for this disease for the sake of eradication, but it's a fabulous question about where you focus your efforts. I've been interested to see that. I think NIH gives a fair amount of funding, more than I would have expected, say, for polio, which doesn't have huge burden, but also has the potential for eradication. So I think there's an interesting tension there.
Okay.
Good, thank you.
Very much. say thank you for your patience in still being here. I know it's been a really long day, but I've enjoyed it. Professor Ryman is actually responsible for me being here and doing at all, so I guess I should say mostly thank you, right? He is the Bunyan S. Womble Professor of Law at the University Law School. He's written and lectured widely on diverse aspects of intellectual property law, including comparative international intellectual property law and the connections between intellectual property and international trade law. His articles in this area have particularly addressed the problems that developing countries face in implementing the World Trade Organization's agreement on trade-related aspects of intellectual property rights, the TRIPS agreement. On other recent writings have focused on intellectual property rights and data, the globalization of private knowledge goods, and he serves as a special advisor to the United States National Academies and the International Council of Science on the subject of legal protection for databases. He's a consultant to numerous intergovernmental and non-governmental organizations, a member of the board of editors, Journal of International Economic Law, and on the scientific advisory board of El Delito de Autore. Did I do it right? Okay. So, and he teaches a fabulous course at the Duke Law School called Access to Medicines, which occasionally I get to participate in, so it's a great thing. Will the other panel members please come up? And you'll recommend them before. So, I hope these are these on? This one's on. Okay. I think they're on. This one isn't. We're going to just spend a very few minutes with him torturing us with a couple of questions about intellectual property agreements and their relationship and issues with global health. And if you all have good questions or patients and wanted to sit and ask more questions, then we're willing to try to answer them. But you want to start with one or two of the questions that we talked about?
Okay, first of all, let me apologize for having missed some wonderful lectures this morning. I had a flat tire out there caused by the Duke roundabout, and it took AAA 2 hours to change the tire. But since we live in a poor developing country, and second of all, let me just take the opportunity to say that some of the related questions will be discussed in our forthcoming book, Governing Digitally Integrated Genetic Resources, Data, and Literature, Global Intellectual Property Strategies for a Redesign of Microbial Research Commons. We look at some of the upstream difficulties in accessing these resources, on which your research is dependent. We had a couple of questions. One of the questions that comes out of our book that's related to here, and I noticed some of you mentioning it, the benefits that come from sharing a lot of these resources, especially data, and we see a lot of progress being made, both here in the United States and Europe. I call your attention to a major project in the European Commission is funding. It's called COMPARE. It's a very long management and sharing of data related to emerging and re-emerging foodborne pathogen diseases. And it's going to be a global database. They're 1 year into a 5-year project, and already it looks fabulous. And one of their main focuses is trying to pinpoint exactly where an outbreak is going and the direction it's going to be able to get there ahead of it. And it looks very promising that they'll be able to do this. So the question that we had here is, to what extent do you think sharing of data is important to the work that you're doing? And how could we enhance that? I could just throw that out there for anybody.
Yeah, well, I could say, from my perspective, that's a great question, Professor Reichman, because we at the Gates Foundation we focus a lot on data sharing. I mentioned, in the context of the collaboration with Gates Vaccine Discovery, that was an important sort of piece that was built into it. And then we have our new open access policy and promote open access to the data underlying peer-reviewed publications, and then looking now beyond that to data writ large. And in that sense, just an example, one of the projects that I'm particularly proud of is the one on healthy birth, growth, and development, knowledge integration, where we're looking at what is it that gives rise to problems with delivery and with early childhood development issues that could be a consequence of a whole range of factors, nutrition being one of them. But in that context, we have, I think, now about 2 million, we have data from 2 million children that are part of that database, and by the end of the year, hope to get up to about 20 million on a global basis. And those data sets, or that data, is going to be made accessible for anyone, that wants to have access to, run whatever analytics they want on the data. The problem here, of course, is, as you would anticipate, has to do with issues around personal privacy. And so, reform consent and so forth moving forward to make that data accessible.
And also underlying intellectual property rights that seep into the database.
Yeah, and then also we talk about it a little bit in terms of desire in some cases for what I call academic exclusivity, that is having a period of time during which
embargoes that have my co-author, one of my co-authors is Paul Mueller, who was head of the data board at the National Academy of Sciences recently. And we have a lot of empirical evidence about to what extent this data sharing is going on. One of the interesting findings that we have is that not only is there an enormous amount of data sharing, open access data sharing, but there's an awful lot of data sharing, we call it semi-commons rather than commons. So it's not open to everybody, but it's open to everybody who's working on a particular project for a length of time. So you get the advantage, all the participants get the advantage of big data. And this is a very promising operation, because in the end, then when the project is over, that data may be made available to everyone.
Actually, that's a great point, because again, with the CVD, and it also said, we talked a bit about the TV Drug Accelerator project, those have provisions within them for the sharing of data, and it has the semi-commons approaches you discussed, and we didn't call it that way, but the idea would be to say, okay, one of the advantages for this group agreeing to come together and to do this work is that they will have an initial opportunity to review data, and that, eventually, as it goes through these various stages, it will then go out to the larger scientific community.
That's really working. Now, there is a negative problem on the horizon, very serious, and we are late in recognizing it in the United States, but it's going to engulf us. And this is the legal claims by developing countries to data, sequence data and genomic data from genetic resources, plant and microbial, taken from their territories. It is clear that the Convention on Biological Diversity covers the data as well as the materials, and it is clear under the Nagoya Protocol, which will come into effect next year, the Nagoya Protocol to the Convention on Biological Diversity, that these complaining governments will be able to go into the courts of the member countries and directly attack products that are produced from non-compliant data. So this will become a very serious problem. We talk to the developing countries that we will come and seize products, your products, in our courts if they don't respect our patents, and they've turned the tables on us and said we will seize your products if they don't respect our underlying claims to genetic resources and data under the Convention on Biological Diversity.
But that's manageable. I mean, the example is the framework.
It is manageable. It is manageable. And that's what we're going to actually, we're going to have a march at the NIH, which funded our work in May 12th. And one of the things we're going to point out, one of the good things about the Nagoya Protocol, even though it makes enforcement tougher, it recognizes a pathway, regulatory pathway for basic research. So as long as you keep your ducks in order and make sure that you're looking where you're getting the data, you should be okay. And as long as the genetic resources are coming out of a multilateral regime, like the International Treaty on Plant Genetic Resources for Food and Agriculture, or other multilateral, the culture collections, the microbial culture collections, the World Federation of Culture Collections, they should be okay. You have to be careful where you're getting your sources from, and then if you're not careful. What will be challenged is the tendency we have among academics to informally trade this stuff, which is fine if the origin is in the United States, but if the underlying, if the data is based on genetic resources coming from outside the United States, that will be risky. You really will need to certify where